بسم الله الرحمن الرحيم. أرحب بكل الضيوف وندخل على طول في الموضوع. طبعا موضوع اللان كانسر، أم، للأسف في بلادنا ما عندناش حالات كتيرة اوبرابل لان كانسر، فالرول بتاع السيرجنز في اللان كانسر ستيل ليميتد. لكن أي حد هيروح أي إكزام سواء يوروبيان أو بريتش إكزامز لازم تبقى عارف إنه تقريبا معظم الامتحان الثوراسيك بارت هيكون على اللان كانسر، لأنه ده المين كور بتاع البراكتس اوف ثوراسيك سيرجنز اول اوفر ذا وورلد. محتاجين نعرف الفاندامنتالز، ازاي الناس بتفكر في المانجمنت بتاع اللان كانسر، ترتيب الانفستيجيشنز، وازاي الناس بتشتغل. انا هتكلمكم عن ازاي الناس بتشتغل في اليو كي. مش لازم دي تكون افضل طريقه، وارد جدا ان المكان اللي حضرتك تكون بتشتغل فيه يكون افضل. النهارده عايزين نخليها انتراكتيف سيشن، نستفيد من بعض ونتعلم من بعض. وارد ان حد يكون بيشتغل في مكان تاني يكون عنده طريقه تانيه تو ابروتش certain cases، فيا ريت نعرفها ونشوف الناس بتشتغل ازاي في كل مكان، لانه في اختلافات حتى بين اليو كي وبين اوروبا وبين اليو كي وامريكا وبين اليو كي والفار ايست، اليابان وكوريا. they are very well advanced في اللان كانسر. فلو في حد عنده انتراكشن، حد عايز يقول حاجة، حد يكتب في الشات على أي حاجة بيعملها بطريقة مختلفة، يا ريت نتعلم من بعض. أنا ما بحبش المحاضرات الجامدة، فمعظم الحاجات النهاردة بتبقى انتراكتيف كيسز. للأسف هنا في ريستريكشن على إن أنا أشير السكانز بتاعت العيانين الحقيقيين، فالصور دي كلها من جوجل، لكن دي كلها سيناريوز بنشوفها كل يوم في الان اتش اس او في البراكتس بتاعنا عموما. طبعا زي ما حضراتكم عارفين اللان كانسر اذا نون سمول سيل، وده اللي بنشوفه طول الوقت، او سمول سيل. سمول سيل غالبا بيروح للأونكولوجيست، الرول اوف سيرجن بيكون محدود شويه فيه. النون سمول سيل اشهر حاجتين الادينو والسكويموس سيل كارسينوما، وذير ار سم اذر رير تايبس، وطول الوقت في overlap between different types، لكن ده يخص الباثولوجيست شويه. التعامل مع النون سمول سيل lung cancer almost the same. The most recent lung cancer staging اللي هو تي ان ام ميتس. اي حد داخل الامتحان للاسف لازم يحفظه، وانا عارف انه موضوع مزعج. انا بتكلم بالذات عن التي ان ام، الجزء اللي على الشمال ده المفروض تكون حافظه، وللاسف الجزء على اليمين المفروض تكون حافظه، ولو اني اشك ان في ناس كتير حافظاه. لكن انا في امتحاني على الاقل كان في سؤالين من الجزء اللي على اليمين وكتير في الشمال، فلازم نحفظ اللان كانسر ستيجنج، ملوش حل غير انه يتحفظ للاسف. أنا بالنسبة لي صعب جدا حفظ الجزء اللي على اليمين، بس دايما بفتكر 2B لأسباب هنجيلها بعدين. يعني دايما 2B هو بيفرق بين حاجات كتير في المانجمنت، هنجيلها بعد شوية. معظم الناس من أول 2B معناها إن التيومر بي أكبر من 4 سنتي، أو 2B معناها إن الليمف نودز بدأت تبقى انفولف، ودي معناها إن الديزيز أدفانس، معانا عيانين محتاجين أدجوفنت كيموثيرابي، هنتكلم عنها بعد شوية. لكن لو انت مش هتقدر تحفظ الجدول ده، يفضل تعرف 2A و 2B لان دول مهمين. بقية الحاجات انا عارف ان هم مش سهلين حفظهم، مش سهل. يعني دي كيس نمبر 1. ممكن دكتور احمد حبيب از ليدنج معايا النهارده، كونسلتنت في ولفرهامبتون، وهيتفضل انه يساعدنا النهارده مشكورا. اتمنى انه يقدر يقعد معانا الساعتين كلهم، بس هو احتمال يكون عنده شويه كوميتمنتس، فنستفيد منه على قد ما نقدر في الساعه الاولى.
ربنا يبارك فيك يا دكتور عبد الرحمن وجزاكم الله خير. طيب، أنا بس حبيت أبدأ بإن إحنا يعني نواسي إخواننا في المغرب، ربنا يهون عليهم ويتقبل موتاهم في الشهداء،
يعني
ويواسي أقاربهم إن شاء الله، ويثلج صدورهم عن من غابوا عنهم، ويهون على من يعني ضاعت بيوتهم وباتوا في العراء. ربنا يهون عليهم ويعينهم يا رب. This is طبعا في الام دي تي عادة، احنا يعني usually when you discuss a cancer case you need multiple specialities, and the usual is that you discuss it in an MDT rather than ان انت تبقى عندك حالة وتبعتها او حد يبعتها لك as an individual opinion. فبتبقى انت قاعد والراديولوجيست usually leading the discussion for the staging. وزي ما انتم شايفين هنا عيانة عندها 60 سنة. She's got a single speculated nodule. Speculations معناها إن الأجز بتاعتها مشرشرة، وده بيبقى ناتج عن بعض الفايبروزز اللي بيحصل حوالين بالذات الادينوكارسينوماز. ودي من العلامات المهمة إن إحنا highly suspicious of cancer، وبتستعمل في البulmonary nodule assessment في app اسمه solitary pulmonary nodule assessment. والاب ده مهم جدا، ممكن اي حد ينزله على الموبايل بتاعه ومفيد جدا. العيانة already عملت PET scan, was discussed in a diagnostic MDT, ورشحوا انها تعمل PET scan, فعملت PET scan. As you can see, there is uptake in the nodule. There is uptake in the nodule. SUV, as I can see, is around 3.3, not very hot, just slightly higher than the blood pool. هتعملوا ايه بعد كده؟ يعني I would like لو حد يحب يكتب في الشات what would be the next stage. So
دكتور احمد، احنا ممكن نخليه انتراكتيف لو حد حابب ينتراكت، يعني يرفع ايده يبقى ديسكشن كانه امتحان. احنا ما نقصدش نمتحن حد، لكن القصه انها تبقى انتراكتيف علشان تبقى منها اقصى استفاده. يعني احنا بنسيميوليت لجان الامتحان الاف ار سي اس، اعتقد ده اللي احنا بنعمله. فلو اي حد داخل الامتحان قريب هتبقى مفيده انه يدخل وينتراكت معانا. وانا اقترح ان الدكتور عامر يتطوع مشكورا انه يبدا، وبعدها نشوف باقي الناس يعني.
Okay, Mr. Abdelrahman,
what would be your next step?
Yes, I will start by chat. There is a comment in chat by Dr. Mustafa. He recommends CT-guided needle biopsy for that lesion. I agree with him.
Okay. Any other options? What would you like to do? Is there anything you'd like to do before a CT-guided biopsy? Oh, definitely a CT-guided biopsy will be needed. But would you like to do something before that? في حد تاني؟ Brain MRI. دكتور حسين الخياط. Okay. Any other options? بس. A CT-guided biopsy is definitely a right choice, but you would like to do lung functions before it. Because if this patient goes into pneumothorax, you will have to defer the lung functions for 6 weeks. So usually you try to get your lung functions, the patient to take a deep breath and blow, prior to sending him to the CT-guided biopsy. Even though it's a rare complication to have a pneumothorax, if it happens, they won't agree to do the lung functions for 6 weeks. So you do the CT-guided biopsy, you do the lung functions. You don't have to wait for the results, even though they come back straight away. And you send for the CT-guided biopsy, and you rediscuss in the MDT. It comes back and says non-small cell lung cancer, most likely adenocarcinoma, and the lung functions are good lung functions. So FEV1, 68%, DLCO, 75%. What would you like to do next? Someone said a brain MRI. Why would you do a brain MRI?
For metastasis surveys, yeah.
Okay. The indications for a brain MRI are either if the lesion is over 3 centimeters, or the tumor is central, or there is uptake in this mediastinum, or the lesion is PET negative and you're not confident that there will be any PET uptake despite spread into the mediastinum. So in this case, it wouldn't be indicated. Okay. MRI, you would do it for stage 3. Screening of the brain is done for stage 2 and stage 3. Stage 2 would be a CT brain. Stage 3 would be an MRI brain. Okay. What would you do next? You got your lung functions. You've got your pre-op histology. You got staging by your PET scan, and you're happy with it. What would you do next?
Okay.
Dr. Mustafa.
Yes, Dr. Mustafa المهنا. Yeah.
هو انا يعني مش نكست، وانا بعلق لان طبعا انا لو سي تي نيدل بايوبسي ابليكابل طبعا، بس لازم اتشيك الراديولوجيست، لان انا شايف الليجن تحت الريب على طول وتحت السكابولا، فممكن اصلا الراديولوجيست ما يعرفوش يعملوا لها سي تي نيدل بايوبسي.
If they say no, we won't biopsy it, what would you do?
Herder score.
Okay, your Herder score here is high. It's way beyond 10%. It's way beyond even 30%. What would you do?
لو هي طبعا مش شكلها مش ابليكابل ان انا اعملها بايدس، فممكن اعمل يعني اخش واعمل ويدج ريسكشن. هي peripheral، فممكن اعمل ويدج ريسكشن وانترا اوبراتيف فروز.
جميل. Froze resection plus minus proceed. What would your aim be if it comes back as cancer? Non-small cell lung cancer.
مش عارف اقيسها بالظبط، بس فور اكزام بيربسز السيفر ان انا اقول بروسيد تو لوبكتومي وليمف نود سامبلينج. وممكن طبعا لو هي صغيره اقل من 200 سنتيمتر على على الستاديز الجديده كال جي بي والجيكوب، ممكن اقول سيجمنتكتوم. انا مش شايف طبعا السكان، مش شايف انهي سيجمنت بالظبط يعني، بس يعني ممكن اقول لو اقل من 2 سنتيمتر اقلب سب لوبر ريسكشن، بروسيد وذ سب لوبر اللي هو سيجمنتكتوم.
Okay, that's good. But you need to be confident that you don't have any N1 disease, yeah?
N1 disease طبعا.
Okay. جميل جدا. All right, you do your operation and the patient goes home the next day or after a couple of days. The histology comes back as non-small cell lung cancer. What will you do after that? It's a T1B and not M not. What would be how would you take it from there? What's the next
T1B T1B ما فيش وان نوت يبقى ما فيش indication لبوست اوب adjuvant وهيبقى regular follow up مع chest physician.
Okay, routine surgical surveillance for 5 years, yeah? Okay, good. ننقل على اللي بعدها يا دكتور عبد الرحمن. دكتور عبد الرحمن تحب تسأل أي حاجة تانية؟ I think he's left us. Okay, let's go to the next one. All right.
Sorry دكتور أحمد.
No problems. 67-year-old male. Sorry.
معلش هو التيك هوم مسج من العيان اللي فات اللي انا حبيت اوضحه هنا انه اي عيان في operable lung cancer should have a PET scan. مش بس operable lung cancer، اي عيان في lung cancer we are offering curative treatment. حتى لو curative treatment دوت كان سيبر او radiotherapy لازم العيان يعمل PET scan. الرول بتاع البيت سكان is increasing. انا عارف ان البيت سكان اصبح more available في مصر على الاقل، ما اعرفش باقي البلاد العربيه، ما كانش على ايامنا زمان available، لكن حاليا البيت سكان اصبح متاح. ف it is not acceptable ان حد ياخد عيان يعمل له resection for lung cancer من غير ما يكون عامل له بيت سكان، الا لو البيت سكان مش متاح، ده مشكله تاني. لكن لو البيت سكان متاح you have to do PET scan، ودوت clearly mentioned في النايس جايد لاينز واكيد في كل باقي الجايد لاينز. PET scan is a cornerstone in staging of lung cancer. ده take home message من الحالة الأولى دي. اتفضل يا دكتور.
تمام، شكرا. Okay. So this is a 67-year-old male, ex-smoker, otherwise very fit, very healthy, presents with shoulder pain and a bit of numbness. And the x-ray shows a bit of haziness in the superior sulcus. You ask for a CT scan and this is what you find. Who would like to take me through this scan?
دكتور عبد الرحمن الجوفي. دكتور عبد الرحمن.
أيوة.
سوري دكتور عبد
الرحمن الجوفي. دكتور عبد الرحمن الجوفي.
دكتور عبد الرحمن بيسي. ايه رأي حضرتك يا دكتور حبيب اجيب دكتور احمد الزكي؟
تعال. اوكي.
هو نفسه رفع ايده. اتفضل دكتور احمد.
تمام. طيب دي suspected for superior sulcus tumor or pancreas tumor based on the symptoms. So I would like to see PET scan and MRI chest as well.
Why do you want the MRI?
MRI to assess the invasion of the brachial plexus and spine as well, and to assess the chest. So chest wall invasion, spinal cord, and brachial plexus.
Okay.
معلش سؤال سريع دكتور زكي. Would you do PET scan first or MRI first?
I would do a PET scan first.
Why?
I think the MRI should be first because if it's invading the spine, maybe I'm not going to offer here curative intent surgery, so it's maybe the PET scan is not useful at this time.
I agree. I think the MRI is needed to work out whether it's resectable or not. I think if it's not resectable, probably there is no curative option and probably there is no need for the PET scan. I'm not saying this is the right answer. Probably some MDTs might do it the other way around, but مش عارف ايه رأيك يا دكتور أحمد.
I would leave the because this is likely going to start treatment with the oncologists. I'd leave that to the oncologists to decide. Even if I'm going to do surgery, they'll provide neoadjuvant treatment.
Yeah.
But that's fine. So you do the MRI, you do the PET scan, it comes back as no lymph nodes in the mediastinum, no hilar lymph nodes, and it's only invading. I mean, this one looks like it's a bit too much into the vertebra, but let's say it wasn't affecting the vertebral bodies and it was just taking T1 route. What would you ask for?
Mediastinal staging, EBUS.
Good. Yeah. The EBUS is done. You have to do it because it's more or less a large tumor over 3 centimeters. And it comes back as negative.
Okay.
What would you like?
Is a CT guided biopsy possible?
Yes. An ultrasound guided biopsy is possible from the neck.
Okay. So I would like to have an image guided biopsy.
Okay. That comes back as squamous cell carcinoma.
Okay, so I have a tissue diagnosed squamous cell carcinoma confirmed, and mediastinum is negative. It's not invading, so it's resectable. So I would like to discuss in the MDT with oncologist to offer the patient neoadjuvant chemoradiotherapy.
Okay, why from the evidence we have with neoadjuvant treatment, what is the advantage of doing neoadjuvant treatment over going straight forward for surgery?
Downstaging of the tumor, or I think that's downstaging of the tumor, or just maybe make the tumor is...
The neoadjuvant treatment the arm with neoadjuvant treatment has resection negative margins better. The survival is the same with both arms. Okay? All right.
I think الارم الثاني اعتقد ان هو افضل في ال تكنيكالي يبقى سيرجيكال، يعني الريسكشن سيرجيكال ريسكشن يبقى تكنيكالي اسهل في الارم الثاني اعتقد without chemoradial therapy. اعتقد الادفانتج بتاعه لو انا افتكر صح يعني. هل ده كلام صح ولا؟
Yes. Okay, good.
take home message برضه في ال superior sulcus tumor إنه this is the only lung cancer where MRI is needed. We rarely use MRI chest, but in superior sulcus tumor, MRI is indicated as part of the preoperative workup. And this is one of the tumors when neoadjuvant is indicated before surgery. I think most European centers would offer patients neoadjuvant before surgery as standard in superior sulcus tumor. I think these are the two differences in superior sulcus tumor. Obviously, it's a very complicated surgery. It's usually done by specifically trained surgeon in superior sulcus tumor in high volume centers. Usually, sometimes two consultants operating is something we don't see very often. And I think if you need to know more about this, you can read in Darteval Group Experience from France. They have a very good 5-year survival. I think much better than anyone else.
Okay.
هو سؤال اكتر لمستر حبيب. هو يعني انا ما شفتش بصراحه يعني سوبر سالكس كتير، بس هو السؤال ان يعني المفروض البوكس بتقول ان انت بتدي نيو ادجفنت، ولو في ريسبونس زي الان 2 برضه لو في ريسبونس تبروسيد وذ ريسكشن. طب السؤال بقى لو ما فيش ريسبونس برضه هبروسيد وذ ريسكشن؟
Is it resectable?
ما هو المفروض نيو ادجفنت، ما اعرفش، هو اللي انا فاهمه ان الرول في نيو ادجفنت ان انت تقدر تريسكت الليجن النهارده، بس انت يعني بتفضل تدي نيو ادجفنت عشان يبقى ريسكشن اسهل. ده اللي انا فاهمه. ده
ان انت تجيب resection margins negative. الريسكتابيلتي بتبقى اصعب من بعد النيو adjuvant treatment. بيبقى التيشو planes very difficult. بس الchances ان انت margins بتاعت الtumor are necrotic tissue are much higher with neoadjuvant treatment. I've only done one of those as a consultant, and I've only assisted in one as a middle grade. I've not seen many of these. It's more likely that when they present, the majority of them that presented to my unit were already inoperable, and when they went for the neoadjuvant treatment, they never came back. So they just progressed.
So
يعني كده انا لو النيو ادجفنت مفيش ريسبونس يبقى ما خلاص ما اعملش بروسيد وذ سيرجري. هو ده السؤال بتاعي.
I don't.
اوكي، شكرا.
هو اعتقد ان to decide resectability بيكون قبل النيو ادجفنت. بتعمل النيو ادجفنت وبتاسس for response, but I don't think this should stop you if it was probably unless it's progressed. I mean, if the patient goes for the new adjuvant for 3 months and the repeat scan shows that the disease has progressed, then probably it's becoming irresectable. But if it was resectable 3 months ago, and if it remains the same or shrink in size, I can't see why not to take him to the. But then I think there are two schools of thoughts for superior sulcus tumor. ساعات النيو ادجuvant بيخلي التيومر يكش ويبعد عن السوبيريور سالكس، فانترا اوبرتيفلي بتلاقي this area بتبقى adherent. فمجرد ما بتعمل دايسكشن، وانا شفت ناس بيشتغل بالطريقه دي، بياخد فروزن سكشن من المنطقه السوبيريور سالكس ويبعتها معلش يا اخوانا المايك عند حد مفتوح.
السلام عليكم. السلام عليكم.
أول شيء تقررات تمسكهم بإيدك التنتين ترفعها تطلع لفوق.
Somebody's mic is open guys. فأنا شفت حد بياخد فروزن سيكشن من ميدياستاينم ويبعتها لللاب، ولو طلع نيجاتيف بيعمل رايت ابر لوبكتومي عادية. This is one of the schools, and the other school is to do formal resection of superior sulcus tumor with resection of the first rib. بس زي ما دكتور أحمد حبيب بيقول هي عموما it's a very rare tumor.
السلام عليكم. Can I add something?
Experience, please. Yes.
دكتور أحمد باموسة من المستشفى العسكري في الرياض. I have actually يعني I don't have a big experience and I have 4 or 5 cases. What I usually do is basically we do PET CT scan, make sure that there is no N2 disease, and if there is no N1 disease, that will be better. Then we discuss it with our make sure that there is no involvement of major brachial plexus nerve, and then we give actually chemotherapy, and then after that we take the patient almost like 4 to weeks after the chemotherapy. We take the patient for surgery. We did the surgery, resect the tumor, make sure that margins are negative. And if there is any doubt, put clips, make sure that this patient will receive radiotherapy post-op. Now, with the new era of the immunotherapy, this is still a big debate. In fact, I asked the expert, what should we do with the immunotherapy if those patients came positive? The good thing that most of those cases are squamous cell carcinoma. But if you have an adenocarcinoma, whether the new immunotherapy play a role, that's a big debate. I thought that somebody will speak about it, and I really need to know about it more. Thank you very much.
Thank you. زي ما حضراتكم شايفين هو في اختلاف كبير بين السنترز how to approach the superior sulcus tumor. وبرضه احنا في بعض السكولز بتعتبر ال N2 disease superior sulcus tumor counts as N1 because station 4R node, for example, is almost in the tumor. So you cannot say the disease has traveled so much if it is in 4R or 2R node. فبالذات superior sulcus tumor should be managed in a big MDT with everyone involved and probably more than one consultant because it's something we don't see every day. And the survival rate is not great. In best hands, the 5-year survival rate is about 40%. So Ahmed, ready to go for the next?
Yes, please. Okay, so a patient comes to you call to the A&E, and a patient is coughing around 150 to 200 mils an hour. You decide to take him and have a look with a bronch, and you find this lesion, you biopsy it, it bleeds even more. What are you going to do? Okay, Dr. Mustafa Mhanna?
ايوه دكتور. هو انا بعمل flexible bronchoscopy صح؟
You're in the GA, you're under GA with a rigid and flexible. You got both in theaters.
اوكي. طبعا هعمل اللوكال ميجرز، هعمل كولد سيلاين، هدي ادرينالين، احاول اعمل لوكال ميجرز ان انا ارست البليدنج، هحاول اخد بايوبسي ويعني ارست البليدنج واحاول اخد بايوبسي وكاري اون ان انا اعمل اللوكال ميجرز لغايه ما البليدنج يستوب. وبعد كده بعد ما البليدنج يستوب هفوق العيان، هويت ريزلت البايوبسي. I think it's suspicious of carcinoid. احاول اصحي العيان.
Okay, that's if it stops. What if it doesn't stop?
What if it doesn't stop؟ ممكن اعمل بالريجيد. الريجيد يعني اعتقد ان الكنترول بالريجيد مش not impossible. يعني ممكن اكمبرس بالريجيد، ممكن ادخل التيوب وانفليت الكف، الاندوتراكيال تيوب وانفليت الكف، ممكن احط فوجرتي، ولو فضل يبليد ممكن ادسكس مع الاي ال ار او اخلي حد من كوليجي يدسكس مع انترفنشنال راديولوجي، ممكن اعمل امبولايزيشن لو possible. وطبعا سيرجري في الاكيوت ستيج سيرجري هخليها يعني لاست ميجر، بس لو هي لايف سيفنج هضطر اعملها. طبعا هريفيو السكانز قبل كده اشوف يعني لو ده تيومر ريسكتبل ولا لا، لو ما كانش حد يعني عارف الهيستوري وريفيو السكان.
Okay, it stops and then you take your biopsy and it comes back as a carcinoid tumor.
Carcinoid tumor هعمل برضه لازم اعمل PET scan.
I'm sorry, but if the bleeding stops, you cannot proceed for surgery. You don't have a consent for that. That's a major surgery.
Dr. Bamus, we're outside theaters. We've stopped. We've controlled. We've done staging.
Oh, okay.
And the histology came back as a carcinoid.
Yeah. But he said that I'll go for surgery.
That's only if all the measures fail and it's a life-threatening position.
Without a consent?
Well, if it's a life-threatening position,
then you will be sold.
Okay,
sorry.
That's fine.
Especially in Europe or States.
No,
forget about this.
You cannot leave
that not waste time. Go ahead, continue. If the bleeding is stopped, most of the time it's stopped.
Consent for bronch, I think, includes procedure.
Yeah. No. Consent for bronch does not include lobectomy.
That's fine.
Okay. في كومنت كمان من استاذنا دكتور بسام درويش. يفضل دكتور بسام.
اسمع صوتي هيك؟
مسموع يا فندم.
يلا.
اهلا.
مساء الخير زملاء، وشكرا
أهلا
على
وسهلا.
الميتنج الحلو. حبيب، بهالحاله هي طبعا بكل الريجيد اللي بنستعمله نحن باستئصال الاورام داخل القصبات، لازم يتوقع الواحد يصير عنده نزف يعني احيانا يكون غزير. طبعا هالاشياء ما بصير الا بمراكز فيها كل الادوات. انا برايي قبل ما نعمل خزعات او نبدا نبرد، لازم نبرد الورم ومع محلول من الادرينالين، وطبعا بده يكون في عندنا ليزر وعندنا هالاشياء. هلا اذا نزف رغزير طبعا انا بقول انه ممكن ندك المنطقه ونسحب ونعمل سكشن بنفس الوقت من فوق القطنه اللي فيها ادرينالين وهي بتكون مثلجه. بهالشكل هذا بياخذ المريض بالجهه الثانيه بالرئه الثانيه الاكسجين، وفي نسبه كبيره جدا بتوقف بهالطريقه هي. هلا اذا ما توقف يعني ممكن الواحد حتى لو كان عنده ليزر ما ممكن انه يستعمل الليزر بهالنزف الغزير، ما بيقدر يشوف شيء. اذا انا برايي الدك مع سكشنه ما فوق القطنه اللي فيها محلول بارد وفي ادرينالين، وغالبا بيمشي الحال بهالطريقه هي. وما في وقت الواحد يقلب المريض او يعمل عمل جراحي، هذا الوقت قصير. لا، اذا نزف غزير هذا لا يستفيد الا بالدك الشديد عبر المنظار الريجيد.
Okay, I agree. Usually, local measures are sufficient.
دكتور احمد، يا ريت بس نرفع الصوت شوي مشان نسمع مضبوط وين.
Okay. الصوت كده أحسن؟
ايه احسن.
كويس تمام.
Okay. Yes. Usually, local measures are sufficient. It's very rare that you need to do an emergency thoracotomy for endobronchial bleed. And if you're really in trouble and you use this lung isolation, that should be sufficient. Most of the tumors, when they bleed, they are PA bleeds. So they're low pressure bleeds. With infectious diseases, usually the bleeding is a bronchial artery, and they're less likely to respond to local measures. But you should know that from before with the history, and hence you wouldn't really put them on table. You'd usually send them to the interventional radiologist to embolize from the start. You don't really get involved in those. Nevertheless, let's move on to the next. Is there any other message you'd like to give, Dr. Abdelrahman here?
لا, I think we need to move on لأنه في.
Let's move on. Time's running. Okay. So this is a 70-year-old ex-smoker with good lung functions, and your respiratory physician did a CT scan and identified two separate lesions. Both of them are PET positive, and the mediastinal lymph nodes are not enlarged and are PET negative. What would you like to do?
السلام عليكم دكتور أحمد. السلام عليكم.
عليكم السلام.
أهلا وسهلا.
I would like to take a full history from the patient and the full examination, and then I will assess each nodule according to the Brock score.
Okay. Brock score is usually for CT scan or PET scan?
Before the PET scan.
Yeah. So now you've got a PET scan. So usually you do a Herder score if they're less than 3 centimeters. Okay.
Right. Okay.
Right.
So both nodules are PET positive.
Yes.
Right. So
how would you stage this?
Sorry for interruption.
So I think Brock's and PET and Herder score, they are not applicable in this case. They are applicable in solitary pulmonary nodule. This is a different scenario. There are two lesions. They're both PET avid. I don't think he can follow Brock's or Herder here.
Okay.
Okay.
Carry on, Dr. Hussein.
So both nodules are PET positive. So either it is two synchronous primary tumors or Mets from. Is the PET scan showing any primary tumor otherwise from the rest of the body? No. So I would like to
take anywhere else.
Okay, so I'd like to take biopsies from both lesions. So from the left upper lobe nodule, I would like to take a CT-guided biopsy. I'll discuss in the MDT, and we'll see if the radiology can take a CT-guided biopsy from the left upper one, and from the right upper lobe nodule. I would say I will see if they can take a biopsy through EBUS or navigational bronch.
Okay. You do preoperative histology, and they come back both as adenocarcinomas.
So both are adenocarcinomas.
Yes, but the morphology is slightly different.
Okay, so it could be two adenocarcinomas, synchronous adenocarcinomas, could be treated separately and staged separately. There is no mediastinal lymph nodes, so it will be according to its nodules, so it's less than 3 centimeters. So both of them will be stage 1A according to the staging, or it will be one same adenocarcinoma. The other one is metastasizing, so it will be stage 4 lung cancer disease. So it will be not for surgery, if that's the case.
Okay, so your thought process is relatively good. So if there's no mediastinal lymph nodes and the histology is either different, squamous or adeno with different morphology or different immunohistochemistry, then you're likely to be dealing with 2 separate synchronous tumors, and you deal with each one alone. Absolutely. If the morphology is similar and the immunohistochemistry is similar, or there is mediastinal lymph nodes, then you deal with it as an M1A.
M1A.
That there has been spread inside the chest.
Absolutely.
Okay. Yeah. Dr. Ahmed
Bamousa.
According to the new staging system, this is you basically, the T is actually according to you divide T and M. T is the biggest size nodule, like for example 2.5 centimeters, and then next to it is M. You put small m, that's indicate that it's a multiple tumor, and then you put the N as 0 and then M as 0 if the histology is different. You treat both as 2 primary. In fact, and if patient have a good pulmonary function test, you do bilobectomy. If not, then you do a lobectomy for the big tumor, and for the small tumor, you do segmentectomy. And then you give, according to the tumor genesis, you give immunotherapy post-op.
Okay. That's fine. Someone's asking in the chat, would you stage the mediastinum either way? Would you do invasive mediastinal staging?
Definitely, yes. You have to exclude that this patient is, because if the lymph node is positive, then we are talking here about T, it will be M1, because that's actually metastasis to the lymph node.
Okay. Dr. Hussam, you were raising your hand?
I would say yes, we need to do mediastinal staging in this case. Absolutely.
Okay.
تمام. يعني take home message. أي حد يpresent 2 tumors, there are one of 2 scenarios. One of them, they are just 2 primaries, separate primaries, and stage each one together, each one alone, and proceed with surgery, or they are just metastases from one to another. And as everyone said, we need to stage the mediastinum absolutely on all those patients to make sure that mediastinum is negative, either with EBUS or mediastinoscope. If the mediastinum is negative, then we can give the patient the benefit of the doubt and assume they are 2 separate primaries and treat them each one alone. Which one to start with?
I would say I will start with the highest stage. So say if one of them is 3 centimeters and the other is 2 centimeters, I would start with the biggest one, speculated.
This is a very debatable thing. So you can say I would start with the more central one because it will likely progress to the lymph nodes. But there is another school that says I would start with the one that ends up with less resection.
Yeah.
I'll be able to offer the patient surgery on the other side because he'll be relying on more lung tissue. أعتقد إنه ما فيش general rule، لكن العيان ده غالبا بندسكس في الام دي تي، والام دي تي تاخد decision. وزي ما الدكتور أحمد قال من شوية، احنا مش يعني في أغلب الأحيان ما بنعملش تولوبكتوميز، بنعمل لوب في ناحية ونحاول نشوف سب لوبر ريسكشن في الناحية الثانية. فإذا كان الناحية تعمل لوب، الناحية الثانية ممكن تعمل segmentectomy. لكن لازم نبقى عارفين انه at the end of the day sometimes we warn patient of this. we could end up, after doing both operations, realizing that this is actually a metastasis. They are both similar tumor, and this is M1A, and the patient had the procedures for no reason.
I had a similar case that was presented to me 2012. This patient was having 2.5 centimeters in the right side, and in the left side, it was like ground glass opacity that we could not biopsy. Did CT scan, negative. We took the patient, we did the biopsy, came adenocarcinoma. We took the patient for surgery, and we thought that would give her the best of the doubt. Of course, the cystoscopy is definite. And after that, we follow the patient. We give antibiotic, assuming that that's an infection. 6 months later, that lesion is getting bigger. We did a biopsy again, and it came to be adenocarcinoma. I cannot remember. It's almost like a year between. Then we did another lobectomy because her pulmonary function test was excellent. And then down the road, after 5 or 6 years, she was doing fine with no recurrence. And suddenly, unfortunately, on the 6 years follow-up, she had a brain metastasis. And unfortunately, the patient died just last year. She survived almost like 9 years.
Yeah. So I think by the way, this is a very common scenario. I think we see this at least in our center, probably once every 2 to 3 weeks, patients with bilateral tumors. It's very common nowadays with more scans. أنا شايف صديق العزيز حسين خياط رافع إيده. يا ريت نسمع صوتك حسين.
السلام عليكم جميعا. تسلم ايديكم ومجهود جميل. يعني small comment ان احنا we have a similar case but we have a bigger tumor on the left side and a smaller tumor on the right middle loop. And what I said that we do it combo. We take the decision of the MDT to do an invasive mediastinal staging with a frozen section on site. And when the mediastinal lymph nodes become negative, we do a VOT switch on the right side and then turn the patient to the other side, and we do a lobectomy on the other side. The pulmonary function was okay, and the patient was doing okay, but the post-operative course was difficult, and the patient was having a synchronous primary, yes.
Yeah,
so
but
I think
very, very aggressive treat. I don't think this is acceptable in the UK. I'm not sure if anywhere else can do bilateral surgery for lung cancer in one sitting. Does anyone else do this?
Usually it's staged.
This is a bit hectic surgery to do both patient thoracotomy on the same side. The patient would not be
it's not an open surgery. But
okay.
Just to mention, yeah, I know it's an aggressive one, but this is what we really do, or what we did in this case. So I just mentioned to reach the discussion, يعني بس نشوف.
Yeah. But you start on the right side first, right?
Yeah, I have a bigger tumor on the left side, so I decide to go from the right.
Small tumor in the middle loop, so you start in the middle loop, and then you go to the left side. Am I right?
Yes,
I think it's right upper. Yeah, it's right upper.
Yes. Right upper. Because you cannot depend only on the left lower loop for ventilation when you go to the right side. That's why you have to start on the right side, the small lesion, and then go to the left side. Although there are some people say you cannot do this because you have to go for the bigger size tumor to make sure that you don't have contraindication to continue for surgery. Suppose that you go to the left side and then you have a pleural metastasis.
Absolutely.
Then you will not go for surgery. But if you have the facilities of doing sorry.
Okay. Can I just ask Heba Bakri, Dr. Heba Bakri.
أيوة السلام عليكم.
تفضلي. وعليكم السلام.
أنا هبة بكري, lecturer of clinical oncology in Asyut University. Thank you for this.
One of our active MDT members. أهلا دكتور هبة.
أهلا دكتور حسين. Regarding clinical oncology point of view, احنا زي ما قال دكتور حسين كده we facing a case like this. أول نقطة زي ما حضراتكم تفضلتوا الفيت positivity والنيجاتيفيتي of mediastinal lymph node does not exclude ان ممكن تبقى mediastinal positive, لان احنا بيبقى في نسبة الفات بيبقى نيجاتيف فيه والميدياستاينوسكوبي بيبقى positive. فقصة ان احنا نعمل mediastinoscopy دي تمام جدا. بالنسبه للمانجمنت بقى زي ما حضراتكم تفضلتوا برضو قلتوا هنستيج 1 separately، وبعد كده ممكن هنعمل المولكيولار تيست ايذر لو طلعت M1. يعني في اوبشنز كتيره دلوقتي بيسايد طبعا الاميون ثيرابي، لو هي BDL1 بوزيتيف، في الانتي EGFR لو هي طلعت EGFR وايلد سوري ميوتانت وي كان جيف خاصه ان العيان هو نيجاتيف كل حاجه، فهنتريت هيم اون راديكال بيز عشان احنا عندنا only 2 سايت. فيعني دي كانت سيميلر فعلا للحاله اللي قالها دكتور حسين من شويه، ان treated the patient on a radical base not at a metastatic. يعني عملنا في الثانيه whatever بقى metastatectomy whatever type of surgery، بس خلاص يعني احنا treat him radically to be in CR stage عشان بعد كده يعني نديله فتره طويله من overall survival.
So can I ask you a question, Doctora? So
Yes.
if you have a biopsy, a BDL
Yeah.
positive, you would give immunotherapy for 2 T1 bilaterally. You will not do surgery, you will give immunotherapy, because I know
T1?
that the surgery will have a better survivor than immunotherapy. Probably after surgery, you will give immunotherapy, but not before. I was just want to make sure that
yes after surgery, yes.
Yeah, thank you very much. I think we are a bit
running behind.
What?
Running behind.
The next case.
Sorry, I didn't catch. I'm sorry, I didn't catch about the if there is a PDL1 expression.
I think we'll leave that for the discussion at the end. We're just running behind Dr. Hassam. Sorry.
Okay, boss. All right. Sorry.
Okay, the next case is a 53-year-old lady who had a fall, and as part of her investigation had a scan on the brain, which identified a solitary lesion in her right hemisphere. She also underwent a CT chest, which identified a nodule in her right upper lobe. How would you approach this?
والله يعني طبعا هعمل الفول اسسمنت اتشيك ان مفيش النوديولز في بقيه الشيست، هبص على كل السي تي هاد واشوف الريبورت اتاكد انها سوليتري. بعد كده هبروسيد ببات سكان والريست اوف انفستيجيشنز واللنج فانكشنز وكل حاجه، واشوف ان العين هيتوليتر ريسكتابيلتي والتراي بارتيت اسسمنت وكل حاجه. طبعا في السنتر بتاعي لو سوليتري برين ميتاستاس هتشيك انها ريسكتابل، يعني مثلا ممكن ريسكتابل او حتى بإيراديشن البرين ميتاستاس، مش شرط مين ويتش مش شرط مين الاول، بس لو هي ريسكتابل والنيوروسيرجن كونفيرم انها ريسكتابل او الاونكولوجيست كونفيرم ان هم يقدروا يعملوا إيراديشن ويكيورت، فهبروسيد with the long resection.
Okay. So Hussein? Well, I'll come to you in a second. Dr. Hussein?
So we confirm that this is a lung cancer from the PET scan and from the MDT. We made to a conclusion this is a lung cancer, and we are dealing with a scenario of oligometastatic disease.
So it's a radiological diagnosis. It is PET positive. But we couldn't do a CT guided biopsy because it's very close to the fissure. So the radiologic diagnosis is based on a solitary lung nodule with a solitary brain metastasis. So it's a T1B and not M1B.
Right. So this is oligometastatic disease we are dealing with.
Yes.
So I think after discussion in the MDT involving the neurosurgery with us, I think this patient should have the brain mets to come out first before lung nodule.
Okay. All right. So by definition, this is stage 4 lung cancer, if our hypothesis is right without histology. And the baseline treatment here is systemic treatment. If you choose to do otherwise, it may be based on individual cases. Okay.
Yeah.
With regards to my unit, these cases are discussed for clinical trials. We don't do them as part of a clinical MDT based on the NICE guidance. We do offer them, if they're fit enough and go by the criteria, we offer them a clinical trial for oligometastatic disease that may be varied. It may be related to oncologic treatment or surgical treatment, depending on the type of clinical trial, Sorin or Rimon or whatever. Other units, like Abdelrahman in Nottingham, they may offer this patient treatment, as Dr. Mustafa and Dr. Hussam mentioned, whereby they deal with each lesion separately. Usually in lung cancer, met is dealt with first, and then the primary is dealt with later. Irradiating the brain and giving SABR is not a minor undertaking. A lot of the patients come back with quite significant debility, and it's not an easy ride. It's a very rocky ride. I'll let Dr. Abdelrahman speak about his experience.
Yeah, in Nottingham, the way we deal with this is exactly as Dr. Hassan said. So we would make sure that this is a lung cancer first by a biopsy. Usually we try as much as possible to take a biopsy. If it's confirmed lung cancer, we discuss at the brain MDT. And if the brain met MDT are happy to irradiate the brain, and we are happy to treat the lung cancer, we send the patient for, as Dr. Ahmed Habib said, we send the patient for the brain met radiation first, wait usually for 6 to 8 weeks, sometimes 3 months, restage another PET scan to make sure the disease has not progressed in the chest, and then offer them lung surgery. I think the crucial point here is the discussion with the patient preoperatively, because the way we sell this to the patient, we don't have a very strong evidence to support this practice. We are not absolutely sure if it is a curative practice or not, because there is an evidence that the survival is better. But it's not a randomized trial to support it. So we always tell the patient, we believe that this will come with better survival. We are not very sure that this is completely curative. And I've seen patients who survived more than 5 years following this. In a very rare cases, one happened last week, we couldn't take a biopsy. So we had to proceed for the lung first with approval from the brain met MDT that they will irradiate the brain. Obviously, this is not ideal, taking patient to general anesthesia while they have a brain met. They can really misbehave immediately following surgery. But this patient went well and she went for brain radiation. But the ideal practice is to start with the brain met and go back to the lung. And as Dr. Ahmed said, it's not a common practice. I wouldn't say it's not common, but I would say it's not agreed practice, and some centers might behave in a different way. It has to be a joint MDT discussion.
Can I add the Toronto experience? In Toronto, we usually actually discuss these cases with the presence of neurosurgery. And if he agrees for resection, not radiation, not cyberknife, they will go for surgery for the brain first, and then later we will do a lung resection. And we have actually survival for those patients. I believe, if I cannot forget about that, it's almost like 35% of our is from Toronto.
Yeah, this is what we tell to patients here. I think we tell them the survival is around 40%. I'm not sure if we are very optimistic, but this is what we tell the patients. I think there is no strong evidence either way. Should we go next?
Yes, please.
Obviously, this is the nice guidelines. بتتكلم عن brain imaging. Dr. Ahmed touched on that. We don't normally do brain scans before surgery for stage 1 lung cancer unless they are symptomatic. I would imagine that this lady was stage 1, but she presented with symptoms. This is why she had a brain scan. And then for stage 2, we do CT scan. For stage 3, we do MRI. Some MDTs do MRI for everyone, but you need to scan the brain in any patient with stage 2 or stage 3. This is next.
So this is an 86-year-old patient who's a smoker, has a performance status of 1, good lung functions. How would you approach this?
دكتور محمد خالد.
I think برضه ان احنا هناخد CT guided biopsy بالنسبة للعيان ده for assessment of histopathology بتاع lung cancer. وبعد كده لو make sure ان هو lung cancer malignant فممكن proceed بعد كده for surgery. انا مش واخد بالي قوي من الأرقام.
Okay. So you do the CT guided biopsy. Would you do a PET scan? Sorry, I didn't hear you saying a PET scan.
اكيد ممكن نعمل PET scan طبعا عشان نشوف اذا كان في اي يعني lymph node involvement او لو كان في اي حاجه اكسترا حاجه بره الشست كافيتي اذا كان في ميتس او اي حاجه ونعمل assessment for the possibility for resection.
Okay. This is a 35 millimeter mass. What would you do with the mediastinum if the PET scan is negative?
Mediastinoscopy برضه to exclude ان يكون في lymph node involvement في mediastinum. زي ما الزملاء الفاضلين قالوا ان البيت سكان not excluding ان يكون في lymph node involvement.
Okay. There are criteria. لو lesion peripheral والبت بتاع الميدياستاينم negative والليجن اقل من 3 سم you don't do invasive mediastinal staging. لو lesion more than 3 centimeters
او هايلر او اكبر
أيوة.
يبقى ساعتها ممكن تبقى susceptible ان تكون جايبه lymph nodes، عشان كده تبقى ساعتها mediastinoscopy as a rule.
mediastinoscopy أو إيباس either way invasive mediastinal staging. تمام.
معلش يا دكتور أحمد، أنا ما أعرفش البراكتس عندكم إيه في ولفرهامبتون but we have to trust PET scan. The sensitivity of PET scan is around 90%, so we cannot just I think the role of mediastinal staging is decreasing in the era of PET scan. زي ما الدكتور أحمد قال في كرايتيريا إن إحنا نعمل إيباس أو ميدياستاينوسكوب. يعني المريض اللي قدامنا ده peripheral lesion PET avid الميدياستاينم is negative in the PET scan, just take biopsy and go ahead. فده
بس I just
زي ما الدكتور قال ان هو بيزد على الليجن نفسها ناخد الديسيجن بتاع mediastinoscope.
Yeah, sorry, Dr. Abdelrahman. I mentioned it was 35 millimeters.
35 millimeters, yeah,
okay.
Yeah.
So I was just about to, I was trying to deceive him, but he was good.
No, my point, Dr. Ahmed, even if it is 35, would you stage the mediastinum in case of negative PET scan?
Yeah, guidelines we all are. You do.
Okay. I'm sorry.
You may have different opinion or local practice, but it is.
I think it's European, probably. This is European guidelines, isn't it?
Nice.
Nice.
To be honest يعني بصراحة mediastinoscope مش regular work up عندنا هنا في مصر. أعتقد إنه ممكن mainly يبقى proceed زي ما الدكتور الزميل بيتفضل بيقول إن هو غالبا بنبقى معتمدين بنسبة 90% على البيت سكان، يعني بنخش mainly على البيت سكان. ف mediastinoscope مش regular practice. بس بالنسبة للجايد لاين زي ما حضرتك بتقول هي based على البوزيشن بتاع الليجن والسايز والسسبتوريتي يكون في lymph node involvement.
هي المشكلة الثانية في الميدياستاينال ستيجنج الديلي، لأنك أنت لو هتعمل ميدياستاينوسكوب أو حتى إيباس it means delay. أعتقد في weeks delay على ما تعمل البروسيجر والعيان يريكفر وتستنى results وتدسكس في الام دي تي، وغالبا العيان هيكون خرج من ال 2 months window هيعوز يريبيت السكان. يعني at least in our center the practice is usually to trust the PET scan unless there are indications. If there is suspicion, if the patient is going for pneumonectomy, if the lesion is very large and very central, otherwise we proceed. يعني 90% sensitivity is not too bad.
تمام. طيب. Okay, you proceed. What would you offer us? What surgery would you offer this patient? Dr. Abdelrahman Elsayed?
Yes, Assalamu alaikum. Sorry, I'm joined late, but I have a small comment about the mediastinoscopy and the mediastinal staging regarding the PET scan. The PET scan, by the way, it is less sensitive for the lymph node enlargement in the mediastinal. If it is less than 1 centimeter, it will not get the mediastinal lymph node. For that reason, if it, as you said, if there is specific indication, it should be done for the mediastinoscopy regardless the PET scan. If it is PET scan negative, because sometimes the lymph node in the mediastinal less than 1 centimeter not be detected by the PET scan. So if the tumor more than 3 centimeters, hilar or central, it is mandatory to do mediastinoscopy as per the guideline, regardless the result of the PET scan, even if it is negative. I'm sorry.
I think it's not a matter of debate. That's guided by guidelines. زي ما الدكتور بيتفضل قال إن based على السايز وعلى البوزيشن بتاع الماس احنا ممكن ناخد الاكشن بتاع الميدياستينوسكوب on top of PET scan. I think احنا كلنا agreed على نفس الموضوع.
You need to remember the guidelines are different. ال UK guidelines مختلفين عن ال European guidelines، مختلفة عن American guidelines، مختلفة تماما عن ال Japanese guidelines. فالمهم يكون عندك guidelines you follow them. أعتقد ده bottom line. As long as
but the point if it is the PET scan not sensitive for the lymph node, if it is less than 1 centimeter, sometimes it will be positive, but it will not be detected in the PET scan. For that reason, it will be false negative. But from this point, they are not depending on the PET scan if it is negative.
Yeah, of course. So
because
I see your point. But if the CT scan is not showing any large lymph nodes and the PET scan is negative, why would you stage the mediastinum? If the CT scan is showing 8 millimeter 4R nodes and the mass is 4 centimeters, you don't need to stage the mediastinum. Anyway, I think it's just a different practice between different centers. That's it. Can we move on? Or my point from this slide, to be honest, is the age of the patient. So the age of the patient is irrelevant. For some reason احنا تعودنا يعني في ان الناس اللي سنهم فوق ال 85 او كده غالبا we don't touch them. which is not fair. If the patient is fit enough and his numbers are okay, we should be able to proceed as usual. So the age is irrelevant as long as the patient is fit enough.
Dr. Abdelrahman, we have 3 raising hands.
Please, yeah, please.
أستاذي دكتور بسام درويش بروفيسور اوف ثوراسيك سيرجري في سوريا.
انا برايي بهالحاله هي ما بحاجه يعمل اذا ما في ضخامه عضليه لا بالبيت سكان ولا يعني البيت سكان سلبي والسيتي سكان ما عم يظهر الضخامه، ما بحاجه نعمل ميدياستينوسكوبي. عندنا ما بنعمل على الاقل، يعني ما بنعمله روتيني. بهالحاله هي ما بنعمله.
أنا أعتقد دعونا نتفق أن البراكتس مختلف from center to another and everyone can follow the guide as long as they have their own guidelines.
Yeah, absolutely. Yeah. Even in the same center, you have some consultants who prefer not to proceed for mediastinal staging, and the others will do that.
Yeah, I think it has to be an MDT decision at the end of the day.
Absolutely. Yeah. 35 millimeters, according to the European guidelines, should have some sort of mediastinality.
I do understand.
But I agree with you, Dr. Abdelrahman, about this. Yeah, if the PET scan is all right, and and the MDT, the radiologist said it's absolutely fine, then we can proceed for definitive treatment for this patient.
I do understand that European guidelines are more invasive when it comes to the mediastinum. I don't think there is right or wrong here.
Yeah, absolutely.
Can we move to
is this lesion separable, Dr. Abdelrahman, with the 35 millimeter?
Yeah.
Is it separable?
What do you mean by separable? Sorry. Saberable. So so the guidelines for
86 years old.
guidelines for saber. So في عندنا هنا في المنطقة اللي احنا فيها في انجلاند اللي هي اسمها الايست ميدلاند الجايدلاينز بتاعت السيبر up to 5 centimeters. بس هم in practice they are not usually happy to offer saber for lesions more than 3 centimeters. ما اعرفش بالويست ميدلاند ايه يا دكتور احمد؟
انا في ليدز.
بس
I was in Stoke and saber can be offered up to 5 centimeters.
I think we'll come to this later إن شاء الله في السيبر. دكتور أحمد معانا ولا مشي؟
دكتور أحمد على الميعاد بالضبط هو مشى.
طيب والدكتور أحمد حبيب عنده ميعاد الساعة 6 فهو اضطر يغادر. طيب next patient he's almost 70. He's an ex-smoker. He's quite fit and well. He has good performance status. And obviously, because as you can see, the scapula and the rib is on the way, the radiologist couldn't biopsy this lesion. How would you approach it?
Okay. Again, يا دكتور حسام أنا عايز أقفل عليك الهاند ريزنج ده. اصبر شوية نشوف حد تاني يا عم. خلينا نشوف دكتور أحمد عبد المجيد. دكتور أحمد عبد المجيد حابب يشارك. دكتور أحمد عثمان حابب يشارك. أعتقد دكتور إسلام جمال حابب يشارك.
السلام عليكم.
عليكم السلام. تفضل دكتور أحمد.
تسلم يا دكتور عمر. أنا أحمد عثمان. ممكن أشارك؟ أيوة تسلم.
تفضل يا فندم.
Okay. So 69-year-old gentleman, ex-smoker, good functional status, good PFTs. They couldn't do a biopsy عشان obviously the scapula is there. I'll put him through the MDT first. We'll get a more imaging in the form of a PET scan أول حاجة.
It's PET positive, SUV max of 11, no mediastinal lesions.
So PET positive, no mediastinal lesion, with very high avidity. Would we do a CT? Would we do a staging CT at this point if we can?
This is the CT. What do you mean by staging CT? Sorry.
CT brain, CT abdomen and pelvis.
So as we agreed, Lise, CT brain, there are certain indications. So if this tumor is 3 centimeters, for example, it means it's still stage 1, isn't it? And no lymph nodes.
True. Okay, so in that case, we'll bypass the CT brain.
Yeah.
We can just go with the PET scan. We don't need to. If there is no lymph nodes on the PET scan, no hot lymph nodes, no targetable area in the mediastinum, I propose we can take him to surgery.
Yeah.
And then it depends on the type of surgery and depends on the center. So it will be a right keyhole approach or a right thoracotomy or whatever the center uses. Frozen section.
How would you consent this patient? This is a very common question in the FRCS exam. They'll give you a scenario and they'll ask you how would you consent.
I'll tell him we can proceed to surgery. After we assess him, we can proceed to surgery. But there's a high chance that there is a chance Of course, after we get the Brock score, the Herder score, then there is a chance that this might be benign. So you might have the surgery done, and the histology might come back as benign.
Yeah.
Usually, when we say that to patients, they're amenable to that option, saying, "I just want it out," and they'd rather know than have it there and watch it. Right? So I'd offer him if it's more than 2 centimeters, so lobectomy and lymph node clearance or lymph node dissection.
Okay. So how would you take the biopsy in theater?
We can do a frozen section.
You'll take a wedge, send it for frozen section. Sometimes wedge is not possible because I think this lesion is a bit big. So in some cases, because of how big the lesion is, you cannot take a wedge. You can't just do a needle biopsy intraoperatively, send it to the lab frozen section, and proceed. And usually patients are happy. The point here, the take-home message here, you don't need to biopsy every patient to take them to theater. If it is a single lesion, you can apply the Herder score, and if the Herder score is more than 30%, it is justifiable to take them to theater for frozen section and proceed. And if it is more than 70%, it's even more justifiable to approach it this way. This is the take-home message in this case.
Okay.
Can see some raised hands.
دكتور محمد خالد وبعد كده دكتور احمد باموسة. اتفضلوا يا فندم.
I'm sorry يعني أنا مش عارف البوسيبيليتي بتاعت اللي أنا هقوله، بس هل إحنا ممكن نعمل للعيان ده فاتس بايوبسي فروزن سكشن برضه، ناخد منه فروزن سكشن، وبعد كده إذا العيان طلع شورلي مالجنت ببقى العيان كونسنتد إن هو يعمل لوبكتومي، وقتها بفتحه وبعمل لوبكتومي، أو حتى ممكن أعمل فاتس لوبكتومي. Is it possible ولا دي حاجة ممكن؟
هو ده اللي بنتكلم عنه يا دكتور، وهو ده اللي نقصده. في وان سيشن بناخد فروزن سكشن وبنبعتها وبنستنى 30-40 دقيقة و then proceed either to lobectomy if it is malignant or stop if it is benign. هو ده حضرتك اللي بتقوله، ده هو بالظبط اللي بيحصل. يمكن أكون ما فهمتش حضرتك كويس.
Lobectomy can be done through VATS as well. I think that was the question. Would you open him to do a lobectomy?
مفيش مشكلة لو انت مش هتقدر تعمل لوبكتومي بفاتس وبتعملها اوبن، مفيش مشكلة يعني still the standard practice، فمفيش مشكلة. إذا كنت هتقصد إنك تقدر تعمل البيوبسي بفاتس لكن مش تقدر تعمل لوبكتومي بفاتس فهتضطر تفتح، مفيش مشكلة. It shouldn't be a problem. بس طبعا it's becoming a standard. VATS lobectomy is the standard nowadays at least in the West. بس لكن لو انت مش بتشتغله مفيش أي مشكلة. حتى في أماكن في اليوكي بتعمل انت بتقوله دوت، لو الجراح ما بيشتغلش فاتس لوبكتومي ياخد البيوبسي فاتس وبعدين لما تيجي كونفيرم يفتح العيان ويعمل اوبن لوبكتومي. ف it's a good practice. There's no problem with that.
Okay. دكتور أحمد باموسة.
Can I just, if the lesion is 3 centimeters centrally, you have to do mediastinoscopy even if it is negative. If it is in the peripheral, so the consent will be mediastinoscopy, proceed for a biopsy. If the lesion is outside the lung, in the outer border less than 3 centimeters, you omit the mediastinoscopy. So you have to make sure what type of consent you are going to do according to the location of the lesion. Of course, you have to make sure that is the pit is actually 11. And 11 is too much high for an adenocarcinoma. Usually, you have to put in your mind, especially in our areas, that 11 could be related to TB.
Yeah.
We have seen a false positive bit, high false positive bit with infections such as TB. So you have to put all of this in your mind, what you are dealing with when you deal with such a patient.
تمام، صحيح جدا. ده طول الوقت بنعمل.
معلش زي انا بس كنت عشان هي دي النقطه اللي انا بتكلم فيها، ان احنا هندخل فاتس بايبسي يعني ميبي اساسا ما تكونش مالجنت
طبعا،
فان احنا نخش نعمل انفيسيف از ماتش از وي كان علشان نعمل جود اسسمنت بيفور ان نفتح العين سوراكوتومي من الاول واخد بايبسي. فده اتفاق مع حضراتكم.
صحيح بالضبط. في حد عنده اسئله ثاني؟
بسام درويش دمشق سوريا. الحقيقه الكلام اللي حكوه زملائي تمام. الدكتور عبد الرحمن نعمل توتال سيرفي بيت سكان، ما في اماكن ثانيه انتقالات، فبنعمل فروزن سكشن بالعمل الجراحي، وعلى نتيجه الفروزن يتابع اما لوبكتومي او اذا في يعني بناين نستأصل فحص الآفي. وشكرا.
اوكي فن. اوكي ثانك يو.
تمام.
Okay, go ahead.
This piece is from the NICE guidelines again for people with non-small cell lung cancer who are well enough, still lobectomy is the standard treatment. In the exam, the question will be, what would you do? You'll say lobectomy, and then they'll say, what is the evidence? This will be the next question. Almost in every question in the exam, they'll ask you what the evidence is. And you can quote the NICE guidelines. So you can say NICE guidelines are suggesting that lobectomy is the standard treatment, but the better answer would be to say that this is based on a trial. Usually the trial is a very old trial. It's called Ginsberg from 1995. This is the one that favored lobectomy over subglobal resection for management of lung cancer. It's a very old trial, but it's still very valid. So always keep in your mind that you'll be asked what the evidence is in the exam. And even if you say something different, if you say that you need to stage the mediastinum, even if it's PET negative, you need to keep in mind that you'll be asked what the evidence is. And if you can back your answer with the evidence, this is the right answer. Yani we'll mimic an FRCS exam, Hussein, ماشي? So you have this 59-year-old patient. He's currently heavy smoker. He's diabetic with COPD. His lung functions are borderline, as you can see. He presented with hemoptysis. The hemoptysis is managed conservatively. Now he's coming to the clinic with this CT scan, obviously ended up with a PET scan. How would you approach this?
So, sorry for that. 59 years old gentleman, current heavy smoker, diabetic COPD, FEV149, DLC or 50%, presented with hemoptysis. From the CT scan, I can see a right upper lobe central lesion and the right upper lobe bronchus, and CT scan showing the lesion, the PET scan showing.
معلش يا دكتور حسن اسمح لي اقطعك. في الامتحان دايما خلي بالك من اللي هو بيسألك عليه. You are wasting your time. I didn't ask you to describe the lesion. How would you approach that?
Okay, so I will approach the patient with the so I will see the patient A, B, C, D, E. How much hemoptysis is coughing.
No, it's controlled. It's controlled now. He's coming on elective basis.
Right. So it's controlled.
How would you treat his problem?
So full examination and then going to then discussing the MDT. So from the scan, I can see, as I said, a right upper lobe speculated lesion in the right upper lobe bronchus.
Okay, what is the next step? He had a PET scan.
So the next step for this patient, after discussion in the MDT, he's got the FEV1 of 49, DLC of 50%. I need to stage the mediastinum given the centrality of the lesion.
Okay. Yeah,
and then
this is not the common practice, at least in my center. The PET scan is negative.
Do bronchoscopy, then take a biopsy.
Excellent. So you need a biopsy now. You did a bronchoscopy, and it is squamous cell carcinoma.
So after the bronchoscopy confirmed the squamous cell carcinoma, can we stage the mediastinum?
Okay. Say we've done EBUS and it's negative.
So EBUS and negative. So this is, I think. This is T2 according to the location of the lesion.
How would you treat him?
So FEV1 is 49 and DLCO 50%. I need to do a tripartite assessment of this patient. I need to assess the postoperative dyspnea. I need to do CPEX for this patient beforehand.
Why do you need to do CPEX? I'm not saying this is the wrong answer. Yeah, I'm not disagreeing.
He's got the FEV1 of 49%. It's DLCO 50%. If we take the right upper lobe for this patient, the FEV1 will be less than 40%. So the risk of postoperative dyspnea is most likely to be happening.
I agree. So this patient will need some additional fitness testing. His CPEX is 17 VO2 max.
17. So that's fine. So is 17 is fine. So it's safe for resection. This patient.
What operation would you do for him?
It's quite central. So maybe sleeve lobectomy for the.
Looking at the CT scan, do you think he needs a sleeve?
Right upper lobectomy.
Yeah, I think right upper lobectomy is fine. The right main bronchus is here, and the tumor is away.
Yeah. If we are away from the right main bronchus, then yeah.
Okay. So I'll ask you exam questions now. How would you consent this patient? What are the possible risks? The most important possible risk.
The most important possible risk for this patient, if we send if there is positive margins and frozen section for this patient, we might need to do sleeve resection?
Okay, I don't think the chances of having positive margin are not so high. It is central, but it's far away from the right main bronchus. There is something more obvious. So there is a more obvious risk of this operation in this particular patient.
I'm sorry, I don't know.
So basically, yeah, the reason why I put this, because in borderline lung function, you need to warn the patient of post-operative dyspnea.
You mean for the risk of post-operative?
Sorry?
You mean the risk of post-operative dyspnea and home oxygen?
And home oxygen, excellent. So you need to warn this patient because, as you said, his post-operative predicted numbers will be less than 40. They need to be aware that they will definitely be more short of breath. They might end up needing home oxygen, and if they are happy to go ahead, you can proceed. This is the take-home message of this slide, and I think it's clearly in the guidelines that if post-operative FEV1 or post-operative FEV1 or DLCO are below 40 or even below 30, you can go ahead, but patient need to be aware that they might end up needing home oxygen.
Yeah, and it's mentioned in the NICE as well. Yeah.
Any questions about this case?
هو انا شايف البت السوبرا كلافز سوبرا كلافيكولار ليمف نودز بت بوزيتيف افيد على البت.
انا مش شايفهم بوزيتيف، لا مش شايفهم بوزيتيف.
انا شايف حاجات حمراء فوق، الرجل.
دي اظن الكلافيكل. I don't think so.
طبيعي ان الكلافيكل تبقى بت افيد.
انا مش شايفها بت افيد، معلش يا دكتور حسام. بس anyway يعني انا للاسف الصور دي كلها من جوجل، انا ما اقدرش اشير حاجه من العيانين عندنا. طبعا الانتربريتيشن بتاع البيت سكان بيكون للراديولوجيست، لو هم شايفين اي suspicious leak you have to discuss it at the MDT. that's a different thing.
سوري يا دكتور عبد الرحمن، انا ليا سؤال. احنا دلوقتي بس علشان ابقى عارف ان العيان ده هيخش ترانس برونكيال بايوبسي، هيتاخد منه فروزن سكشن on the same setting، هيحصل عادي يعني هاخد منه بايوبسي وهيخرج عادي.
It doesn't work this way. So usually this is done by the respiratory physician قبل ما العيان يجي لك خالص. فالعيان بيجي لك غالبا يعني ممكن يتناقش في الام دي تي قبل ما يتاخد بايوبسي، وانت بتطلب بايوبسي بيشتغلها الريسبيراتوري فيزيشن awake flexible bronchoscopy وبياخد بايوبسي وبتروح اللاب وبعد اسبوعين العيان بيجي لك، فهو جالك متشخص يعني. This is usually not your role. ده غالبا respiratory physician.
أنا عندك سؤال دكتور عبد الرحمن بعد إذنك. I'm always confused about sleeve resection. And when can I, because in the exam I had this problem previously. When I can say this is close to the right main bronchus and we shall proceed for sleeve resection or not.
طيب ماشي، ولو تصبر علينا يا دكتور حسام في بعد كام شريحه في حاجه هتكون اوضح ان احنا نبين احنا هنعوز سليف ليه. بس هنا الرايت مين برونكس هي اللي انا مشاور عليها بال far away، يعني ممكن تشتغل العيان دوت سيفلي فاتس بدون مشاكل. انت انتراوبراتيفلي بتعمل برونكوسكوبي تشوف how far the tumor is from the segmental bronchi, and if the right main bronchus is fine you can safely do lobectomy.
Any cut-off margins, then we can say, oh, this is okay, this is away.
You should be more than 2 centimeters far away from the mass.
From the mass, the right main bronchus should be 2 centimeters far away.
No, the area you will make your cut, which will be the right upper lobe bronchus. So the right upper lobe bronchus is here. The mass is further away. I don't think there is any problem here. Obviously, you'll do more assessment by the bronch in theater, but this shouldn't be a problem. I'll show you more obvious cases, Sir Hussain.
Teslam barakallahu feek.
Should we move to the next?
Sir Abdelrahman, can I add something for the last case? In such case, probably I will do VQ scan to make sure if I'm going to do a lobectomy, how much that lobe is receiving from ventilation as well as perfusion, because that actually will help me in the post-op care.
Yeah, I agree. We do VQ scan for some patients, but I wouldn't do it for this particular patient. Probably if his numbers are less than that, if it is 40 or 35, and I'm very keen, and the patient is young, and I'm very keen to give him curative resection, I would do VQ scan. But I think even if EV149, you take 3 segments, it will go down to probably 40.
I will go, but from my understanding, he's a chronic obstructive airway disease emphysematous patient. So you have to make sure what are you when you do the surgery.
Yeah. So the thing is, how would this change your decision? This is the question. You'll do the VQ scan. The VQ scan comes back that the upper lobe is participating exactly the same as the lower lobe. Would you stop?
No, but suppose that it's the main ventilation that then I know that the patient will end in a ventilator.
No, but
So I have
so the right upper
you get
lobe
my
in
point?
COPD. Yeah. Yeah, أنا متفهم طبعا اللي حضرتك بتقوله. هو غالبا الرايت upper lobe في السي او بي دي patient is less functioning، فأنت بتدور على less function مش more function. مش بيحصل إنه يبقى الرايت upper
No,
lobe.
I have to confirm it.
Yeah. I cannot disagree. يعني لو عايز تعمل VQ scan عشان دي borderline to check how much of the function you are removing, you can justify it. As long as you can justify it, it's fine. And as long as it doesn't delay the operation so much. The problem, if you do more investigations, you delay a lung cancer patient and they end up with N2 disease. But
I think
you can just.
I think, Dr. Abdelrahman, if we do a CPEX with a MVO2 17, if it is less than 15, then VQ scan will be reasonable. However, 17 is a very good.
Is good, and actually CPEX might not be available everywhere. You can do less invasive tests. You can have the patient. You can just walk with the patient for 400 meters, the shuttle walk test, and in the NICE guidelines, if they can achieve 400 meters without significant drop of their saturation, they are fit in
absolutely
operation.
دكتور محمد رافع ايده اول مره يرفع ايده، فرفعت ايده عزيزه علينا.
السلام عليكم، يعطيكم العافيه شباب.
عليكم السلام.
It's important انه لما نتحدث احنا هون عن حاله رايت ابر لوب كانسر صحيح السنترال، ما في disease within the main bronchus او the bronchus of the right upper lobe، فعاده ما في indication انه ينعمل سليف. just little bit of comments انا بحكي. هلا اذا كان في انه الواحد is planning to do a vasulobectomy وال putting a stapler across the bronchus is going to compromise the margins, there's an indication انك تعمل sleeve. This can be assessed intraoperatively or during the bronchoscopy itself. So this is the usual thing. على second thing, I've heard comments على موضوع الميدياستاينوسكوبي والإيباس وما إلى ذلك. As long as there are no PET avid nodes, and as long as the nodes in the mediastinum are 1 centimeter and less, and they are PET negative, there is no indication to do EBUS or mediastinoscopy. And this is I'm an examiner for FRCS. This is how you should be answering. So you will only do EBUS or mediastinoscopy if there is lymph node enlargement, or if there is PET avid nodes, or if there is contralateral disease and you are suspicious that there might be already involvement and metastasis to the other side. These are indications in you're planning to do something really massive and big that the patient will not tolerate. In this patient, المريض عنده FEV1 of 49%, so we're going to take 3 segments out of 19. It will drop to 41%. A NICE guideline بتقول لك it's okay, you don't need to investigate any further. So as long as he's above 40%, he's fine. Even the new NICE guideline اللي نزل جديد بقول لك as long as the patient FEV1 predicted post-operative goes down to 30% and the patient is accepting home oxygen, then you are okay as well to proceed. هلا احنا كsurgeons we always investigate when we are in that borderline because we are worried انه المريض يصير مع significant complications and mortality. So as part of your proper assessment, the most accurate test is CPEX. So CPEX is above 15, so you are safe to do a lobectomy. Above 20, you are usually safe to do a pneumonectomy. طبعا في شوية precautions تانية مع الإيكو وشغلات هاي. But you don't need to do a VQ scan if the CPEX is good. هلا إذا كان في question mark، يعني مثلا إذا مريض عنده FEV1 let's say in the 28% وعنده significant upper lobe predominant emphysema, severely badly emphysematous disease، هون يصير في value للVQ scan. لأنه we're talking about completely different type of strategy in managing the patient, and we want to make sure that this patient would be offered a chance of a cure. This is the only thing. فحبيت بس أعلق على هذه الشغلات وجزاكم الله خير.
دكتور محمد طبعا he's my mentor. احنا مش عارفين نستفيد منه لأنه عنده conflict of interest، فهو بيستمع من
أختلف معك يا دكتور محمد. See the guidelines saying if you have a lesion adenocarcinoma in the periphery of the lung 3 centimeters or less, you don't need to do mediastinoscopy. There are 10% of patients with central tumor that you have a PET negative and size is negative. Those when you do
any guidelines at Ahmed.
This is the new guideline. This is the guidelines.
Any guidelines?
This is from the TNM staging, the last edition. When we move from the 7th to the 8th, they put that if you have an adenocarcinoma 3 centimeters in the periphery and the face that PET is negative, you don't need to do mediastinoscopy. But you have a central lesion which is 3 centimeters or less, and you have a PET negative, a CT scan negative, there is 10% that those patients would have a positive. Therefore, those you should have to do whether to do EBUS or you would do mediastinoscopy. You have to confirm that the nodal staging, the mediastinal staging is negative.
أخي الحبيب أنا أحترم رأيك. In an exam setting في ال FRCS you have to follow the guidelines الموجودة في ال UK سواء كانت ال BTS guidelines أو ال NICE guidelines. On both of them they don't mention the need to do cervical mediastinoscopy or EBUS for PET negative mediastinum أو a mediastinum which doesn't have any lymph nodes which are يعني كل الليمف نودز تكون below 1 centimeter يعني ما في enlarged lymph nodes. فthis is the UK setup.
Despite being central, Dr. Hawari, Mr. Hawari, sorry. Despite being central, we don't stage the mediastinum if it is negative.
هلا يعني شوف if there are nodes which are enlarged يعني you have to investigate خاصة if you are going to do a sleeve or you're going to commit yourself to doing a new.
I could send you the evidence. Just send me the email and I could send you the evidence. I'm not sure about the guideline in Britain. I'm following the guidelines in North America. And this is what we are doing.
That's absolutely fine. No, يعني الخلاف مش راح يفسد العلاقة يعني ما تقلق توكل على الله يعني في اختلاف.
لا أنا I'm just telling you what we are doing.
But I'm just telling you this is the standard that we are following in the UK يعني.
And I'm telling you this is the standard in North America and the standard in Saudi Arabia.
خير إن شاء الله.
معلش أنا آسف. السلام عليكم دكتور محمد. I'm really sorry. I'm now confused. If the PET negative and the CT and PET are negative for lymph nodes and even if the lesion is central, we don't stage the mediastinum.
هلا لما يكون عندك يعني إذا في عندي tumor 4 centimeters or 5 centimeters sitting in the right upper lobe with PET negative mediastinum with no enlarged lymph nodes at all, I proceed with a lobectomy if there is a diagnosis or if the patient is happy to proceed with a frozen section and proceed if we are unable to take a biopsy or if the patient does not want it. Okay. If the lymph nodes come back as positive as like N1 disease or a single station N2 disease or even a multi-station N2 disease اللي هو completely incidental, then you are going to proceed with adjuvant treatment accordingly. What is the chance of this happening is extremely low if the PET scan is negative and if there are no lymph nodes which are more than 1 centimeter in the mediastinum. So this is the standard that we are following in an exam setting for the FRCS.
Because I have been criticized before when I mentioned mediastinal staging a lot. I've been given a feedback that I'm digging for the mediastinal staging a lot.
Yes, probably this is the reason. فمثلا أحكي لك في UK for example يعني doing mediastinoscopy has dropped down significantly in the UK. They're mainly doing EBUS and so on, but as part of a staging, if there is a need for it, either to find a diagnosis because of enlarged lymph nodes. But this, I think this is going to be a controversial thing for all of us. بسبب اللي change guidelines between different areas. فأنا بحترم الآراء المختلفة وكلكم ما شاء الله عليكم يعني. بس أنا بتحدث عن موضوع الامتحان فقط لا غير.
جزاكم الله خير بوس.
حياكم الله.
Should we move next then?
Yes, sir.
مين حابب يشارك؟
Yes, sir. Go ahead, Dr. Abdelrahman. For case 9.
Okay, he's 79, left upper lobe nodule. It's small cell lung cancer. Only PET avid, the mass is PET avid, no other lymph nodes.
الغريب يا دكتور عبد الرحمن ان حضرتك جايب كل الحالات اللي ينفع نشتغلها ودي الحالات دي مش بنشوفها الا نادرا.
عارف والله بس هو في الامتحان هي دي الحالات اللي هتشوفها ولو جيت ان شاء الله عندنا دكتور عامر هتلاقي هي دي الحالات اللي بنشوفها. It is still less, it's around 20% of patients we can operate on in the UK. يعني أنا عارف الأرقام دي عندنا هتكون أقل من كده بكتير لكن most of the majority of lung cancer patients are still inoperable even in the UK. فيعني بس ده اللي احنا بنشوفه كسيرجنز هم دول العيانين اللي بيجوا لنا باقي العيان ما بنشوفهمش أصلا. discussion مع الأونكولوجي.
تمام فندم.
هو السمول سيل لانج كانسر، هو الليجن انا مش عارف حجمه قد ايه، بس هو شكله صغير يعني، شكله within يعني 2 سنتيمتر.
29
فطبعا كام حضرتك؟ 29 يعني within still T2A. فطبعا هبروسيد بالنورمال بري اوب اسسمنت وسي تي سكان. في السمول سيل لانج كانسر دايما لازم اعمل ميدياستانال ستيجنج، دي حاجه. تاني حاجه هاسس هدسكس في الام دي تي. السمول سيل لانج كانسر في رول للسيرجري ما دام هو within T2A، عشان كذا حاجه منهم ان ساعات بيبقى ميكسد باثولوجي، بيبقى معاه جزء نون سمول كمان. وتاني حاجه T2A في رول بس as a part of multi modality، يعني لازم العيان ده هياخد بوست اوبريتيف نيو ادجمنت، بوست اوبريتيف ادجمنت، وممكن كمان ياخد بري اوب نيو ادجمنت. وبس يعني هو ده باختصار يعني.
هي take home message برضو من النايس guidelines انه it doesn't mean they are not for surgery even if they are small cell and they are still T1 or T2A and no nodal involvement or no metastasis, they can go for surgery. Take home message: small cell lung cancer is not a contraindication for surgery. I'm afraid
نقطة كمان نقطة كمان أنا قريتها في كتاب أمريكاني إن دايما حاول تاخد second pathologist opinion، عشان ساعات بدل الحاجات دي confusion ساعات بتطلع أصلا كارسينويد في الآخر، فخد second pathologist opinion برضه.
طبعا في similarity بين السمول سيل والكارسينويد في الهيستوباثولوجي زي ما الدكتور قال. anyway, small cell lung cancer is not a contraindication for surgery. You can proceed as long as it is within the staging of T1, T2A, N0, M0. This is nice guidelines. Next, this is 64-year-old patient, presented with chest infection, had a CT scan and chest X-ray. Can someone stage this?
Staging?
Staging. حد ممكن يقترح staging?
This is if these lesions are in the same loop and they are all cancer lesions. I mean the same primary cancer lesion. It's T3.
It's T3. Yes, you're right. So the patient is performance status 1, good lung function test. How would you treat this?
So if it is T3, then we'll do a PET scan and see the PET scan result.
Okay. It is still T3N1 M0.
So T3N1 means stage 2B.
Okay. How would you treat this?
So I'll discuss in the MDT, and then I will do a PFT for the patient tripartite assessment.
Good as I said here. So it's good.
So, yeah, sorry, I didn't recognize that. So good PFT is 64 after assessment of the patient with tripartite assessment. If he's candidates for surgery with the stage 2B, then we can consider left upper lobectomy and adjuvant chemo.
Yeah, excellent. So this patient will benefit from left upper lobectomy and he will go for adjuvant chemotherapy. Let us say that the same patient is actually almost bedridden, performance status 3, most of the time in bed due to other comorbidities. And you've seen this CT scan and you are in the MDT while this patient is being discussed. What would you say?
So the patient has got lots of comorbidities. Sorry?
What would be the next step?
Oncology.
Okay, would you do a PET scan?
Yeah. I thought that it's already done.
No. So no, it's just the CT scan. The patient is at the MDT, and this is the scenario. The patient is performance status 3. 3 has too many other comorbidities.
Okay. So if there is a curative intent, then we do PET scan.
Yeah, excellent. So this patient will not need a PET scan. Basically, we operate on patients with performance status 0, performance status 1. Performance status 2, you cannot deny them the treatment altogether. You need to know why they are performance status 2. They might have a knee problem, and this is why they are performance status 2. So you need to assess patients with performance status 2, and we can sometimes offer them curative treatment. But performance status 3, we do not offer them curative treatment. If you're not offering curative treatment, there is no need to do PET scan. This patient will be for probably best supportive care after the MDT discussion. The take-home message here is some people with lung cancer will not be well enough for treatment. وده لازم تاخده you need to take this into account when you're arranging your preoperative investigations. حد عنده أسئلة؟
هو طب حتى لو مش في سيرجري اعتقد ان احنا هنوفر هيم كيمو، ممكن نوفر هيم كيمو او اشوف لو الانكولوجيست هيعمل مثلا سيبر لو هو ينفع يتعمل له سيبر او راديو فريكونسي ابليشن. اعتقد ان هم هيعوزوا سي دي بايوبسي. اعتقد ان هم
دكتور سيبر is still curative treatment، والراديو في radiotherapy curative treatment وفي palliative radiotherapy. فعلى حسب انت what is the plan. Are you trying to cure the patient? In this case, you need to do PET scan, you need to do brain scan, you need to work.
اعتقد ان هو ممكن في اوبشن، يعني لو الانكولوجيست هيقدر يوفر حاجه، يعني هيقدر يوفر حاجه كيوريتيف، اعتقد ان انا محتاج بروسيد. يعني انا قصدي مش عشان مش هعمل له سيرجري انا بديناي يعني كيوريتيف.
لا احنا ما اتكلمناش على سيرجري. If you are planning for curative treatment, then you need to do PET scan and brain scan. In performance status 3, it's very unlikely anyone will offer this patient anything. It's usually best supportive care. You cannot take patient who is a bedridden and take him to the hospital for chemotherapy. They will die straight away. So usually performance status is a very important part of assessment, and you need to know performance status very well before your exam.
Okay.
Next, this is an 81-year-old patient. Sorry, we have to run quickly. I think just 10 minutes left. 81-year-old lady. She had a screening CT scan, and the screening is increasing nowadays. Screening CT scan. She presented with this 11 millimeter nodule, spit avid. Her score is above 90%. There are negative notes. Her numbers is borderline, as you can see. How can you stage this, and what kind of treatment would you offer?
Stage 1, stage 1A. This one.
It's 11 millimeter. So T1. Oh yeah, it's fine. T1.
T1B and 0. M0.
T1B and 0M0 borderline lung function. Do you know which segment this lesion in? Roughly. أنا عارف طبعا أنا مش قادر أديك CT scan كامل بس what do you think?
It might be in the lower lobe apical segment.
تمام. Excellent. So what are the options of treatment?
So the options of treatment would be she has negative nodes, she's 81, borderline lung functions. Oh, we can follow it up. So depending on the MDT.
So always, this is a very good answer, by the way. So always in the exam and in real life, offer the patient the option of doing nothing. It's clearly mentioned in the NICE guidelines as well. So always offer the patient the option of, first option is to do nothing. Option number 2?
Option number 2, since it's early stage, we can, well, she's 81, borderline lung functions. I wouldn't necessarily, we can biopsy it. But it's quite...
It's too central. It's difficult to biopsy. The radiology is not happy with this poor lung function to stick a needle in.
The other thing is to assess her for a sublobar resection, frozen section.
Okay.
And yeah.
Would you be able to do frozen section in this case?
If it's an apical segment, possibly yes.
To be honest, looking at this CT scan, obviously you need to see the full CT scan. It might be difficult to biopsy this lesion to do frozen section in theater. Is there another option apart from doing nothing or surgery?
We could do saber.
Saber, yeah. So the way we explain this to the patient, there are 3 options. Option number 1 is to do nothing. Option number 2 is to do saber. Sometimes they can do it without diagnosis based on certain criteria. If it is growing and PET positive, they're happy to do saber without diagnosis. Option number 3 is to do surgery, and you rightly said the best surgical option here would be probably sublobar resection. What is the evidence? Do you have any evidence to support to do sublobar resection for this patient?
The size of the tumor. It's the size of the nodule. Sorry, it's
no. I mean, that's fine. So it is 11 millimeter. Herder score is high. You are proposed to do sublobar resection. Do you have any evidence to support this practice?
I do have evidence.
This would definitely be the next question in the exam.
Okay. No, I can't comment on that. I have the evidence, but I cannot actively recall it.
So you
the JCOG trial.
Yeah, you can quote the NICE guidelines because the NICE guidelines are be somewhere here. The NICE guidelines are suggesting that you can do sublobar resection for tumors less than 2 centimeters, but the ideal treatment would be to quote the very hot topics nowadays. You need to know them by heart if you are going for the FRCS exam and declaring yourself as a thoracic surgeon, which would be the CAL-GB or probably the JCOG first and then the CAL-GB trial. The 2 trials that came in favor of of segmentectomy even over lobectomy in tumors less than 2 centimeters. You need to know the criteria. You need to make sure that lymph nodes are negative. But I think you need to know those 2 guidelines by heart. The last slide, I mentioned the titles of these trials, just in case you need to read them before the exam. The take-home message is You can do sublobar resections for tumors less than 2 centimeters. The ideal sublobar resection is segmentectomy, but it's not always possible. If the lesion is peripheral, less than 2 centimeters, patient is borderline fitness, you can do wedge resection, and this is supported by the CAL-GB trial, not by the JCOC trial.
Okay.
يعني في بعض الحاجات من النايس guidelines. The NICE guidelines is very specific about the TLCO, so you need to do DLCO for patients before lung resection. ممكن تكتفي بالFEV1, but they need to be probably performance status 0. The ideal lung function test is FEV1 and DLCO. طبعا لازم قبل ما تعمل الريسكشن لازم تحسب الحسبة بتاعت كام سيجمنت من 19 predicted post operative، وعلى أساسها بتحدد زي ما الدكتور محمد قال من شوية إن العيانين حتى لو predicted post operative هينزل تحت 30% and they are happy to take this risk and they are happy that it's almost certain they need home oxygen or most of them will need home oxygen, you can proceed. واحد تاني من ال very valuable preoperative fitness test is shuttle walk test, which is very easy to do. I know that CPICs might not be available everywhere. If the patient can achieve 400 meters without significant drop of their saturation, without significant jump in their heart rate, they should be okay to go ahead with CPICs. والأرقام بتاعت CPICs والNICE guidelines بتقترح رقم 15 as a cutoff number.
I have a question, Dr. Abdelrahman. For this lesion, is it separable?
Sabrable, yes, it is sabrable. Obviously, we don't take decisions for saber. There'll be an oncology at the MDT specialized in saber. They have their own criteria depending on size and the place. They don't like very central lesion. This is called the no-fly zone.
Yeah.
So anything closer than 3 centimeters from the mediastinum, they don't like it. But you have to, the one who takes this decision is the oncologist who does the saber. So they need to be at the MDT. And whenever there is a lesion like this, even if as surgeons we think it's resectable by surgery, we ask them at the MDT. If the patient doesn't want to go for surgery, are you happy to saber this? They would say probably yes or no. And then we can discuss this with the patient.
Okay, I mean, in the exam setting, we can say, we'll discuss in the MDT various options, which is 1, 2, 3, and then we'll let you know what is the best option of treatment for you, and then the patient will decide which option he would like to proceed with.
Absolutely. So basically, it is limited stage. It's in the lobe, so it's surgically removable. But at the same time, we would like to know if the SABR team are happy to do it. Always surgery is the best option. If the patient is willing to go for that surgery is the best option, then comes SABR, and if they don't want anything done, conservative treatment. Next.
Case 11.
We're nearly done, so probably two more cases. So we have to run quickly, I'm afraid. This is a 73-year-old patient, loss of weight, CT followed by PET showed this 27 millimeter mass, good PFTs. This is the only, so this is not the full PET scan, obviously, but 4R node is positive. How would you stage this?
Stage 3A?
يعني أنا بتكلم بالتي ان ام غالبا، ده اللي بنسأله، ده غالبا اللي يقصدوه في الامتحان لما يقول لك how would you stage this?
Yeah, stage T1, this is less than 3 centimeters, 27.
Yeah.
So T1C, N2 disease, so stage 3A.
تمام. T1C N2 disease. The patient has good lung function. Patient is performance status okay. How would you treat this?
So after MDT discussion, I would like to do a brain CT, brain MRI for this patient, given that is stage 3.
It's negative.
Is negative, and the patient has good PFT, and he is operable patient. I'll discuss with the oncology team about various options. He might have surgery with the right upper.
I think the lesion in the fissure, doctor. In the fissure.
We lost you.
Yeah. Hello? This is an MDT consensus should be taken. I would discuss in the MDT about various options. This patient has got stage 3A disease and single station N2 disease. Various options of treatment may be available. So he can have right upper lobectomy with mediastinal lymph node sampling and adjuvant chemotherapy, or can have neoadjuvant chemo and downstage and reassess with a CT scan again, and then proceed for surgery after neoadjuvant chemo.
This is a very excellent answer. So well done. I think if you say this in the exam, you'll clearly pass. So are you aware of any new evidence supports neoadjuvant?
Yes, there is the new checkmate trial, which is a neoadjuvant chemo and immunotherapy, durvalumab.
Excellent. So in the UK, there is a new NICE guidelines released in 2023. And this is in light of the checkmate trial that showed that those patients respond better to neoadjuvant chemoimmunotherapy followed by surgery rather than surgery followed by adjuvant chemotherapy.
Absolutely.
It is increasingly more popular in the UK nowadays. And I think if you are going for the FRCS exam declaring yourself a thoracic surgeon, I think this will definitely be asked at some point of the exam. Any questions? Okay, so offers EBUS for biopsy of paratracheal and peritracheal nodes. So let us tweak the scenario a bit. We don't know the diagnosis of this patient. He presented with this scenario and there is no diagnosis. What would you do? How would you get the diagnosis in this patient?
I think EBUS.
You mean a preoperative biopsy for this patient? EBUS will be
excellent
for the lymph node.
So if the radiologist is happy to do percutaneous biopsy and the respiratory physician is happy to do EBUS, which one would you choose?
It's EBUS
because it will upstage the lesion.
Excellent. So yeah, you're right. So it will give you staging. Yeah, you're right.
Hello?
Yeah. So EBUS is the preferable option because it will give you the diagnosis. It's a diagnostic. We can hear you, Doctor.
So I would say EBUS first.
Yes, you're right.
EBUS will be the answer because it will upstage.
So yes, you're right. So it will be a diagnostic. It will be diagnostic and staging EBUS. So they can take a biopsy from this node, and they can sample other lymph nodes as well. So they can sample 2R and 7, although they are PET negative, but they could be positive with the node, and then it means it's multi-station N2. And it changes everything. So EBUS is the right answer to this question. How to get a preoperative diagnosis is EBUS, not needed biopsy.
Yeah, absolutely.
And it is clearly mentioned in the guidelines as well. Choose investigations that gives the most information about diagnosis and staging. Think carefully before performing a test that gives only diagnostic pathology when information on staging is also needed. This is a clear guide from the NICE guidelines. Consider surgical mediastinal surgical staging for patients with negative EBUS if clinical suspicion of nodal malignancy is high, and we've discussed this. دكتور اللي كان بيسأل عن السليف دكتور حسام أظن.
أيوة باشا.
طيب. This is 47-year-old man presented with hemoptysis. Bronchial biopsy showed squamous cell carcinoma. He's fit and well. إيه رأيك في السليف؟
Yeah.
This is a clear sleeve, isn't it?
Yeah, clear, yeah.
Mass in the right main bronchus. You'll do a bronch, you'll see the mass. This patient clearly needs a sleeve.
Yeah.
Other option?
Absolutely.
What is the other option?
Other option of treatment for this patient?
If you don't know how to do sleeve.
Pneumonectomy will be one of the options.
Yeah, I wouldn't say this in the exam. Probably I would say in the exam, I'll find somebody who can do a sleeve because pneumonectomy nowadays is considered as a bad quality indicator. If a unit does more pneumonectomy than 5%, they need to investigate this because it's not the ideal treatment. In the era of bronchoplastic procedures and sleeve, you need to do your best to make sure that you are able to spare as much as possible of the lung tissue. Pneumonectomy is a disease itself. Yes, we do it every now and then for patients with lung cancer, but if this is the only way, then you do pneumonectomy. I'll give you a question came in my exam actually. So this is a patient, you did sleeve resection, you sent the margins came back positive.
So I'll call a more senior colleague to come and help me in the case.
To do what? To come and do what?
Pneumonectomy, completion pneumonectomy.
Wait, what sort of surgery you did? Sleeve upper lobectomy?
Sleeve right upper.
And probably you need to do a sleeve, you will do sleeve for the carina. If you don't have an
basically, yeah, you're right. So basically you take more. You still can take more. So just check which margin is the positive one. Is it the proximal or the distal? And if it is the proximal, as doctor said, you can just go slightly higher to the carina. If it is distal, go slightly lower to the bronchus intermedius. But if it is still positive, then the right treatment is pneumonectomy. Do not stop there. It is a lung cancer surgery, and obviously pneumonectomy has to be in the consent in patients coming for sleep. You need to be prepared for pneumonectomy. You need to do all preoperative tests for pneumonectomy, because you could end up needing pneumonectomy in those patients. I think we are overrunning, so we'll quickly discuss this patient. He's 15.
In the exam they will ask you what other tests that you need to do intraoperative to make sure that the patient can go for pneumonectomy.
Yeah, you should have prepared this preoperative by echocardiogram.
Now, what else intraoperative?
You can
clamp the PA, give it a few minutes and see how the patient will.
Thank you. You have to put the patient in normal oxygen. Yeah, clamp the PA for 5 minutes, do an ABG and go.
Yeah, but you have to be prepared preoperatively by consent and by echocardiogram, and the patient need to be aware. Pneumonectomy is a disease, and they need to be aware about that. This is a 59-year-old patient presented with loss of weight, biopsy adenocarcinoma. Again, the rest of the imaging are suggestive that pneumonectomy is the only curative option. His FEV1 is 58, his DLCO is 55. PFTs, these are two different scenarios. In the first scenario, this is the lung function test. How would you approach this? خلينا spot diagnosis. يعني عايزين الإجابة على السؤال.
ممكن consider PA sleeve.
You can consider PA sleeve. Well done. But احنا قلنا هنا إنه كل ده طبعا ده intraoperative assessment، بس للأسف it's not possible. The disease is involving the whole PA all the way to the very proximal PA. So PA sleeve is not possible. He needs a pneumonectomy, and these are his numbers.
So if this is the numbers, is the left lung function?
It's a very good question. How to assess that?
Do a bronch and see the lung window.
Exactly. So
the lung window.
No, VQ scan is the right answer here. So دكتور قال VQ scan هذه الإجابة الصحيحة. أنت عندك you will lose the left lung. الأرقام دي لو left lung is functioning normally, you cannot take it out.
Yeah.
Probably you can, but he will end up with less than 30%, and he will likely need home oxygen. It's a very high risk surgery. The best answer is to do VQ scan, because this tumor might be completely blocking the PA, and he's not using the left lung anyway.
Yeah.
The VQ scan shows that he's only using the right lung, then he can safely do left pneumonectomy. But if both lungs are equally contributing, then you need to make sure that the patient is either aware. If his numbers are less than that, I wouldn't do surgery for him, because he will end up with 25 numbers, which is too high risk, and then you can refer him for chemotherapy. Dr. Amir بيقول palliative. Don't rush to say this in the exam. They don't like that. And if you deny a patient who is in his 50 the curative treatment without thinking carefully, they don't like this in the exam. I had the same discussion with one of the consultants, and I said, it's not operable. He wasn't very happy. And we ended up with the discussion that it is not operable, but you shouldn't say it like that. You need to make sure that you've done every possible effort to make sure that you can offer this patient the curative option before saying palliative treatment or he's not for surgery.
Okay.
The same patient, the same.
VQ scan يا دكتور بعد إذنك، لو VQ scan طلع إن totally encroaching PA واللفت lung مش شغالة أو مش functioning معايا، هل بيبقى فيه رول نيو ادجوفنت، ولا أنا خلاص بخش كده على طول على نيومونكتومي وببروسيد؟
طبعا للنيو جايد لاينز العيان ده هيحتاج نيو ادجوفنت. طبعا للنيو جايد لاينز اللي نتكلم عنها العيان ده هيحتاج نيو ادجوفنت والبنفيت فروم نيو ادجوفنت. بس لان لسه الموضوع جديد في اليو كي، احنا حاليا في مرحله ان احنا بنحكي مع العيان نقول له والله في ايفيدنس جديد بيقول النيو ادجوفنت افضل، تحب تروح الاوبشن دوت ولا تروح للجراحه ونشيله الاول؟ بندي الاختيار للعيان. but I think this will change very soon لانه الايفيدنس is very strong. طيب نتخيل نفس
العيان. I have a question on this with this patient, Dr. Abdelrahman, I'm sorry. And this patient who's most likely to have any patient with a sleeve who's possible for a sleeve or pneumonectomy, I think must have mediastinal staging beforehand, because if there is a possibility for pneumonectomy to proceed, if there is N2 disease,
This is the next question دكتورة. احنا اي عيان فور نيمونكتومي او possible نيمونكتومي بنعمل له mediastinal staging. طبعا بنعمل ايه بس لكل الناس دول. طيب نفس العيان دوت اللung functions are good, his numbers are not that bad, لكن ال PET scan showed positive nodes. What would you do?
I think we prepared the patient for pneumonectomy, but preoperative neoadjuvant will be considered.
I doubt. We don't do pneumonectomy for N2 disease. Some surgeons do it, but results are not great. So the standard practice is not to do pneumonectomy for N2 disease. One of our local surgeons in our unit does it, and his results are not too bad. His 5-year survival in N2 disease pneumonectomy is around 27-28%, but this is not the common practice. Usually, if there's N2 disease, we don't do pneumonectomy, we refer them to chemotherapy. Offers more extensive surgery, bronchoangioplastic, like sleeve PA, bilobectomy, or pneumonectomy only when needed to obtain clear margin. يعني the standard treatment هو lobectomy. If you need to do more, you need to be able to justify it. 71 millimeter left upper lobe adenocarcinoma, left upper lobectomy, pathological staging T4. طبعا أنا هنا بس بتكلم على ال post operative treatment. أعتقد كلنا عارفينه. What kind will he need any further treatment? Adjuvant chemotherapy. وطبعا على حسب الباثولوجي هو adenocarcinoma 71. لو هي طلع EGFR positive, he will go for immunotherapy as well. This will be part of the next slide. So offer post-operative chemotherapy. وده طبعا based على meta analysis مشهورة اسمها LACE meta analysis to offer chemotherapy للعيانين دول. Do you know how much better survival does it give them?
5% في الليس ميتا اناليسيس 5%. حاجه ثانيه هو EGFR مش immunotherapy، هو اوزيمرتينيب، هو نوع من الادجوفنت بس مش اميونو. اعتقد هو الاوزيمرتينيب مش اميونو تقريبا.
لا ما اعتقدش. انا اللي اعرفه ان الاوزيمرتينيب اميونوثيرابي. ده بارت من الادورا ترايل. امال هو
الادورا ترايل الاوزيمرتينيب والحاجات اللي اخرها دي مش اميونو. الاميونو اللي اخرهم اب اللي هو بروفالوماب والحاجات دي.
It is actually a target therapy, not immunotherapy.
Exactly, targeted, not immunotherapy.
طيب هم عشان كده يمكن هنا يعني بدأوا يبطلوا immuno كيمو ويسموهم حاليا systemic anti-cancer treatment عشان يجمع كل المصطلحات دي.
بالظبط.
Sorry, what was the question? Sorry, Dr. Abdelrahman, because I lost signal.
الكويستشن بس انه احنا بنتكلم على انه مين العيانين اللي بيعوزوا adjuvant chemotherapy، وبنتكلم على ان ده بيزد على الليس ميتا اناليسيس. اظن دي ما فيهاش حاجه جديده. ده عيان 35 ودي كارسينويد. الدكتور حسام كان بيسال على السليف. What do you think he can do for this patient?
He can. It's very proximal to the cranium.
What would you do? طيب انا يعني عشان بس نختصر الوقت، انت لو بصيت ممكن تعمل right upper sleeve، وممكن تعمل complete parenchymal sparing surgery if you are very skilled. يعني it needs a lot of experience obviously, but you can cut in the right upper lobe bronchus intermedius and the carina, and you can reconstruct the whole carina. It's a bit complicated surgery. لكن لو بصيت على السكان in more details البيديكل بتاع التيومر ناحيه الرايت ابر لوب، الحته دي ما فيهاش حاجه، هي مجرد بس compression. طبعا you'll confirm with the bronchoscopy. The take home message again is to preserve as much lung as possible, not because he's 35 and you are bored and you don't want to spend time in theater, you do pneumonectomy for this patient. Spend every effort to preserve as much lung as possible. Upper lobe sleeve.
But because you could see that the right upper lobe parenchyma is normal. So in those cases, just open the bronchus, take out the tumor, and do sleeve reconstruct.
Exactly.
Because the upper lobe is not destroyed.
Yeah, absolutely. This is the take-home message: is to preserve as much lung as possible. And if you're not able to do that, don't just chop the lung. Find somebody who is able to do it.
Absolutely.
Updates and publications. الناس اللي داخله الامتحانات يعني في نيو، اتكلمنا عن التشيك ميت ترايل والنيو نايس جايد لاينز اللي بيتكلم عن نيو ادجوفنت. مهم جدا جدا جدا. It's a very hot topic in thoracic surgery. الجيكوج والكال جي بي اللي بيتكلموا عن الادفانتج اوف سيجمنتكتومي في الجيكوج والسيجمنتكتومي والويدج ريسكشن surprisingly في الكال جي بي. وحاول تقرا الانتقادات بالذات للكال جي بي لانها فيها فاليسز كثيره. الجينسبرغ ترايل is a very old trial وهي اللي قالت انه اللوبكتومي احسن من السبلوبر ريسكشن. It's very old. I don't think we need to use it so much. بس هي الجولد ستاندرد وهي لغايه دلوقتي.
Depend upon your examiner. I'm sorry. Depend upon your examiner. If your examiner is an old guy, you have to mention this. This is very important trial.
Yeah, of course, it's a very important trial. You need to know it. You need to know it absolutely. فايلوت ترايل طبعا دي الترايل الشهيرة اللي بتقارن الفاتس بالأوبن وطالعة very promising. It says that the VATS is not inferior oncologically and it's better from the functional status and recovery. I think you need to know it. Latest meta analysis واتكلمنا عليه الأدورا ترايل برضو it's coming في EGFR positive adenocarcinomas which increasingly applicable. فده اللي عندي واعتذر على ان احنا تأخرنا.
عبد الرحمن, can I share one slide, 1 minute?
Please. Yeah, you can, absolutely, yeah.
So if you share my screen, just...
Should I stop sharing? عامر أنا مش خبير في الزوم للأسف. Are you able to share it?
I'm able. Can you see the slide?
We can now, yes.
Okay. This actually been published in the European Journal Cardiothoracic Surgery 2014 for mediastinal staging. And you could see that if mediastinal negative, okay, mediastinal negative on PET CT or CT scan, tumor is centrally more than 3 centimeters, you have to do a tissue confirmation for mediastinal staging, either EPUS or EUS or video-assisted mediastinoscopy. If the mediastinal lymph node is negative, you go for surgery. If not, and this actually you could say that there are 10% of cases with a negative PET as well as a negative CT scan, they usually be positive. So I'm not sure if this is not going actually, if this is not the recommendation, but I have not came in any staging that they omit the mediastinal staging for central tumor. And this is my evidence, and it was published as a 14.
يعني طبعا احنا زي ما الدكتور هواري قال احنا مش يعني مع احترامي لرأي حضرتك هو ده زي ما حضرتك قلت دي اختلافات بين الجايد لاينز. احنا للاسف heavily based على اليو كي عشان الاف ار سي اس exam is UK. This is a very old evidence. هنتكلم عن 10 سنين. انا
never have been changed up to date.
أنا متأكد إن اليوروبيان جايد لاينز are more invasive مع الميديستاينال staging. أنا متأكد من الكلام ده. لكن اليو كي جايد لاينز are different. لو أنت رايح اليوروبيان بورد exam, probably yes, you're right. You need to quote European guidelines. If you're coming for the UK exam, you need to use the UK guidelines.
حبيت بس أوضحها.
متشكرين على المعلومة المفيدة. لكن زي ما حضرتك بتقول يعني كل إذا كان عندكم في السعودية بتستخدموا النورث أمريكان جايد لاينز فمفيش مشكلة. الواحد بيتبع الجايد لاينز اللي في المكان بتاعه. لكن في اليو كي we use different kinds of guidelines. فهو ده يعني. لكن بارك الله فيك على السلايد الممتاز. ويا ريت نستفيد من حضرتك حتى في محاضرة عن الميديستاينال ستيجنج يا دكتور أحمد.
حبيبي الله يرضى عليك. لا يعني بالعكس يعني أنا دخلت interest cases. It was very nice and I really thank you very much. Very nice discussion. الله يعطيكم الصحة والعافية.
نشوفك على خير دايما.
شكرا دكتور عبد الرحمن, والله يعني محاضرة ما شاء الله فيها كل حاجة ومعظم السيناريوز وعلمك جزيل ما شاء الله. وألف
الله يبارك فيكم. متشكرين لكم جميعا.
والله يا دكتور الرحمن, والله جزاكم الله خير وبارك.
شكرا زملاء يعني شايف.
شكرا دكتور عامر.
اي والله
شكرا دكتور عبد الرحمن, والله بارك الله فيك.
بارك الله فيكم جميعا.
نشكر كل الزملاء والله اللي شاركوا واللي قدموا, وكانت الاكسلنت الحقيقه الميتينج. والشكر الاول والاخير للدكتور عامر الحقيقه.
اكيد نشكر الدكتور عامر طبعا. شكرا, بارك الله فيك. السلام عليكم.
شكرا دكتور عامر,
جزاكم الله خيرا.